would be very obliged if all of you stick to your 10 minutes. Become difficult for us to keep a watch only in this webinar because our webinar administrator is a little occupied.
Realize.
A very good evening to one and all of you for an interesting learning webinar update series in corneal lamellar keratoplasty. Today, we have the very best on the expert panel and a very learned set of speakers who would journey us through all that we need to know about lamellar procedures of the cornea. Before we break off into this webinar, I want us to pause, pay our homage to some great human beings we've most unfortunately lost in this pandemic, and many more very precious loss of loved family members and best of friends. We from ARC grieve for all of them and would pray strongly and stand strongly with all of you in these very, very tough times. Dr. Mukherjee is no longer with us, a doyen in ophthalmology, a clinician, surgeon, and a teacher of very high standards with a commitment to take ophthalmology many, many strides forward. We would really miss this very noble personality, a loss to our fraternity forever. I would request our respected Dr. Titiyal to speak a few words about Dr. Mukherjee, whom we've lost most unfortunately. Dr. Titiyal? Dr. Titiyal, you're there? Yeah.
Yeah. Thank you, Dr. Chitra. Can I share a slide for him?
Yeah.
As the COVID has taken its toll in country, and that has not spared all of us in terms of our friends, relatives, or colleagues. They all have suffered, and we have many people who are sick at this time also. It is my real honor to say something on our teacher or colleague, senior advisor to various societies, Professor Dr. Govinda Mukherjee, who is no longer with us. And he has been with us for so many years in various aspects of our functioning, not only in societies, but in our life also. He did his MBBS from Calcutta Medical College. Subsequently, he came to RP Center, where he did MD and did a registrarship in cornea. And he joined RP Center as faculty. And subsequently, he took VRS and at a stage of additional professor in cornea unit, started his own practice in Delhi, and he was a leading cornea practitioner in Delhi for last 4 decades, supported by his son, Dr. Rajiv, who's been a very active force behind various societies also. He received many awards and honors, and most importantly, he did receive a Lifetime Achievement Award from various societies, from ISCRS, Cornea Society India, AIOS, DOS, ACOIN, and received the silver medal from Calcutta University, and is recipient of Austrian government Global Fellowship in 1974-75. In fact, he was a visiting professor in Vienna also, and received a DOMS degree from Vienna. He served various societies, and he has been secretary and president of DOS, and his contribution to DOS cannot be forgotten. Especially for me, he was a guiding force behind me when I was secretary and president of DOS. He was currently president of IBANG Association of India and Ocular Trauma Society of India, and past president of Indian Society of Cornea Keratorefractive Surgeons. Notably, he was a teacher to teachers. We all know him, and he received oration from DOS also, SN Mittal and PK Jain, and Air Marshal Bopara gold medal from Ocular Trauma Society of India. I think nothing much can be said in terms of his contribution to our society. We are indebted that he was there behind us in all respects of functioning of societies. And I feel for Rajiv, who's going to take over whatever he taught us in respect to humanity, working for our students. He was a teacher for all of us, especially in the cornea, and he did so much work in Delhi to uplift the corneal eye banking systems, the teaching in DOS. And I think this is my humble request to people listening to us, that we do give a respect to our departed soul, not only for Dr. Mukherjee. So many of our colleagues have left us. I feel for them and their family, and pray to the God that we do respect this pandemic and save ourselves and our families. And humbly, I pay respect to Dr. Govinda Mukherjee. Let his soul rest in peace.
Thank you, Dr. Titian.
Just as Sir was talking about Dr. Mukherjee, one more ophthalmologist from Delhi has passed today, Dr. Ravikant Gupta, and his wife, again due to COVID. So just wanted to put.
Thank you, Dr. Namrata. We shall now go on to our expert panel, Dr. Jeevan Titian, who leads the team, who heads the cataract, cornea, and refractive surgery at RP Center of Ophthalmic Sciences, and has had over 180 publications to his credit, two books, 27 chapters in various textbooks, and some most coveted international and national awards, and awe-inspiring long list of orations to his list. We have with us Dr. Namrata Sharma, Professor of Ophthalmology, RP Center, Honorary Secretary of AIOS, who has led AIOS amazingly in these difficult times with an astuteness beyond her years, and of course has all those amazing number of publications, mind-boggling lists of awards and accolades. We have next on our panel Dr. Rajesh Sinha, another great professor of ophthalmology, RP Center, who's also the honorary treasurer of AIOS, a quiet, consistent, hardworking person, a very impressive leader, and a surgeon of great repute and talent. We have with us next Dr. J.K. Reddy, Director, Shankara Eye Care Institutions, an extremely innovative and a brilliant surgeon to add strength to our webinar. We have with us another very dynamic surgeon, Dr. Srinivas Rao, who after a solid, strong tenure at Shankar Nethralaya, a stint as a professor in Chinese University of Hong Kong, started his own surgical center as a director of Darshan Eye Care and Surgical Center, has published extensively, authored textbooks, mentored fellows in his Cornea Fellowship Program, a truly prolific personality and teacher par excellence. Dr. Bhaskar Srinivasan, another senior consultant of C.J. Shah Cornea and Refractive Services at Shankar Nethralaya, is a highly proficient surgeon, especially in the various parts of lamellar, cornea, and refractive procedures, significant publications in oculus of his disease, as well as keratoprosthesis, and is actively involved in the cornea PG training program with his great skill sets to impart valued learning to these aspiring students. Dr. Jagdish Reddy heads the Cataract and Refractive Services L.V. Prasad Eye Institute, adjunct Assistant Professor of Ophthalmology at the School of Medicine and Dentistry, University of Rochester Medical Center, with a great academic career, a very prolific surgeon, great number of publications, has actively published his research in various peer-reviewed journals, and individual of great standing. Moderating with me is Dr. Rajesh Fogla, all eminent personalities here, and he's an amazingly capable cornea and refractive surgeon with a very vast experience, presently consulting in Apollo Health City, Hyderabad, after a major stint in Shankar Nethralaya, visiting consultant to Apollo Hospitals, Colombo. A very impressive educational career and innumerable awards and accolades to his credit, and a surgeon par excellence. We shall now go on to our first speaker, Dr. Praveen Krishna, Director, the Cornea Institute, Head of Refractive Surgery, Cataract and Contact Lens Services, Consultant Cornea and Anterior Segment, who has again another great personality with an excellent academic career, an amazing number of publications and awards to its credit, and extremely astute surgeon. He would be talking on an interesting subject, femto-assisted anterior lamellar keratoplasty. On to you, Dr. Praveen.
Thank you so much, Dr. Chitra, for having me on this course, and thanks to...
You'll have to share your screen.
Yes, I haven't started yet. I also thank all the panelists and the AIOS ERC for this opportunity. And it looks like it's a fantastic group of speakers as well as topics that you've put together today, both for learners as well as for experienced surgeons. So the topic that I'm going to be speaking to you today is on femtosecond anterior lamellar keratoplasty, or FALK. FALK is something that probably has limited accessibility because you need a femtosecond machine to do this, but it certainly has its place in the management of anterior cornealopasties. So where is it useful and who might benefit from FALK? Typically, patients who have pathology limited to the anterior stroma of the cornea, like anterior stromal corneal scars or corneal degenerations that are in the anterior stroma like BSK, or corneal dystrophies that tend to be mainly in the anterior stroma like granular, will tend to benefit from FALK. Now, it's also important to choose the correct patient for FALK because FALK is not for everyone. And to do this, you should be able to choose or differentiate corneal lesions that are elevated and that are non-elevated. Let's look at a couple of examples. This is an example of a patient who has a non-elevated corneal lesion. This is haze after PRK. So the ideal procedure for this patient actually might be a PTK because the lesion is also quite shallow. So for elevated lesions like this, the ideal procedure again might be LK and not even an FALK. And I'll explain why that is so in the two case examples that I'll share with you. So for PTK, if you can actually distinguish between elevated and non-elevated lesions, if you have a non-elevated lesion and a smooth epithelium or an irregular epithelium, with a smooth epithelium, you can do something called a transepithelial PTK. Whereas if you have an irregular epithelium, you'll probably need to debride and then do your PTK. So that's the general approach when you have somebody who has an elevated or a non-elevated lesion. So this is an example of a non-elevated lesion that I showed you earlier. And if you do a PTK for this, you actually will get very good results, as you see in this picture, immediately post-op, where most of the lesion has been removed by the laser itself. But if you have an elevated lesion like this, you might actually use a different approach where you can just go and peel these Salzmann lesions from the cornea, and you will get a very good outcome like this. But then what do you do when you have lesions that are more diffuse and present in the anterior stroma of the cornea, but also are a little deeper where you can't do a PTK and you can't really do a debridement? Well, that's when ALK or femtosecond ALK comes into the picture. ALK typically is going to be covered later, but typically this is a method where you can either manually or using a microkeratome remove the corneal tissue that has the scar and replace it with a clear corneal tissue. Typically, post-ops of ALK will require sutures, mainly because of the fact that you have some amount of mismatch between your graft and your host bed. But FALK actually negates all of that because the tissue matching by making your lenticule, your donor, as well as your host bed with the femtosecond laser will ensure that the fit is extremely accurate in both these instances. This is making the femtosecond donor lenticule from the anterior stroma of a cornea. And this is making the cut on the recipient cornea using the femtosecond laser again. And because of the fact that the depth is the same and also the diameter is the same, you typically do not need to apply sutures in this. And so time to rehabilitation is very short in these kind of patients. So all you have to do is dissect off the lenticule from the anterior surface of the stroma and then make sure that you place the new dissected donor corneal lenticule on the bare bed that you have and wait for it to adhere just like you would wait for a LASIK flap. So that's as simple as how FALK is. Now, the problem with FALK is if you have lesions that are scattered, you can have the laser that tends to go into the stroma quite easily. And you will have very good outcomes like you see here in this patient with granular dystrophy, mainly present in the anterior stroma. But if you have lesions that are more dense like this scar, what you will also see, like in the bottom picture, OCT, though the picture looks like the FALK has done a great job, but the OCT shows you that the residual bed is actually quite irregular. And this is a problem with PTA, with FALK. And even electron microscopy studies in patients with FALK have shown that the deeper your lesion is, the more irregular your cut becomes. So FALK should be limited to those patients who have superficial lesions. Let's look at a couple of case examples. This is a 25-year-old female who had a contact lens-induced bacterial keratitis. She was a myope, -5 and -4, and with a best corrected vision of 20/40, and she wanted refractive surgery because she did not want to wear contact lenses after this episode. So if you look at the picture of the eye, you see there's a scar right in the center. And if you look at the slit picture, you see the scar is about half the depth of the cornea. On the OCT also, the scar is about 230 microns or so deep. So we did an FALK for this patient, and we see that the scar is mostly removed from the cornea. And you'll see that structurally it's a great outcome. But what happens is the fact that this patient still had this refractive error. Visual acuity really did not improve a lot. And the reason why this was so was because there was some residual scar in the stoma that we left behind. So what we did was we lifted the flap of the FALK, then did a PTK to the residual stoma, and then this patient had better visual acuity improvement, improving to 20/40 with correction. And eventually this patient underwent a PRK and then had a very good visual outcome with 20/25 uncorrected visual acuity. The advantage here was the fact that we added tissue with the FALK so we could ablate the refractive error later on. And that was the advantage. But then we must remember that functionally FALK might not be the best surgery in all cases. Now let's look at our second case. This is a patient who is a 25-year-old female who underwent microkeratome LASIK and then underwent 3 episodes of flap lift and scraping because she had epithelial ingrowth. And when we saw her, this is how her cornea looked. She had partial resorption of the flap and dense epithelial ingrowth. And you can see that this is limited to about 200 microns from the anterior surface of the cornea. So for this patient, we did an FALK again. What we did was we used the Zeiss Visumax laser, again, no financial interest. But then we created the lenticule from the host bed, and then we excised and we dissected this off the cornea. And there are a couple of interesting things that you will notice here. Once you dissect, you see the dissection is not as smooth as you saw in the earlier case, and that's because the ingrowth was relatively dense. After we removed this, then we replaced it with a clear lenticule that we sourced from a donor cornea. The patient did relatively well, and this is the patient in the first month post-op. And you'll see the OCT shows that the ingrowth has been completely removed. There is some irregularity of the stomal bed. But eventually, with time, she did really well. And she, after a PRK on the surface, achieved a best uncorrected visual acuity of 20/25 again, which I think is a really good outcome for this patient after FALK. So when you are looking at a lesion, to summarize what we've learned about anterior lamellar keratoplasty and FALK, I told you that first thing you need to do is to decide whether the lesion is non-elevated or elevated. If you have a non-elevated lesion, and if you have a smooth or an irregular topography, if you have a smooth topography, you also should measure how deep the lesion is. If the lesion is less than 100 microns deep from the anterior surface of the cornea, then the ideal surgery to do is probably a PTK because you'll only be removing a limited amount of tissue. If the topography is smooth, but the lesion is extending more than 100 microns beyond the anterior surface of the cornea, that is where FALK probably has a very good chance of giving a good outcome for these patients. If the topography is irregular or the lesion is elevated, like I said earlier, and if the lesion is less than 250 microns from the surface, you can do a manual LK that you'll hear about later. Or if it is greater than 250 microns, you can consider doing a DARC. In case the lesion is elevated, then probably you should not be doing a PTK or a FALK, but move directly to doing a LK or a DELK. So to summarize about FALK, FALK is useful for anterior stomal scars as well as for dystrophies that are located mainly in the anterior stroma. Ensure that you limit doing FALK only for cases with regular corneal topography so that your outcome also results in a patient who has a regular cornea. Usually do not do FALK in patients with dense scars because you will get a good structural outcome, but you will not get a good visual outcome. There are some issues with interface irregularity and haze if your planning is not accurate. Sometimes you have sizing issues, but uniformly you don't need to use sutures with FALK. So you will be providing very early visual rehabilitation for these patients. And that I see is the biggest advantage of FALK over the other anterior lamellar procedures or even procedures that will need sutures. Thank you very much.
Thank you, Dr. Praveen. That was an amazing talk. so crisp and clear and so well within time. I have a question to ask before I would ask Dr. Rajesh. How would you end up, what would happen if you end up with an undersized or an oversized graft, which might occur rarely, and what are the tips to avoid?
Well, I think that's the same question that Rishi had asked. So typically, early on when we started doing FALK, we always try to oversize, learning from our keratoplasty days by 0.1 millimeters. So if the host bed was 8, then the donor was 8.1. We had a few patients who had oversized grafts, and what happened in those cases is that there were a lot of folds on the Bowman's layer, and that resulted in reduction in visual acuity for these patients. So we went to same sizing grafts after that, and that sometimes lead to undersizing. But even if you have an undersized graft, the gutter that you leave behind is covered very well by epithelium. And because of the straight cut of the femtosecond laser, epithelium doesn't go under. So if it's an undersized graft, still completely okay to leave it alone. Epithelium will fill the gutter and the patient has a much better visual outcome as compared to a graft that is oversized. So typically now we just use the same size graft, donor as well as host for all. There is a little more caveat in this one because the curvature of the cornea will also affect the size of the graft. Typically, if you have a cornea that is more curved, then you will get a host bed that is slightly smaller. That's the other caveat.
Dr. Rajesh?
Yeah, actually, the point is, I was just about to ask Praveen that what he does regarding sizing, because a couple of studies have shown, they have shown 0.1 millimeter oversize, one study showed 0.2 millimeter oversize. Whatever I have done same size. And what happens that initially it shows the gutter on day one because the stroma is a bit thickened. But once the stromal thickening reduces, the edge to edge, because of the vertical side cut, that's the beauty of FALK. Which has an advantage over the microkeratome that way. Apart from the size of the lenticule, which can be customized better, the side cut vertical, since it's vertical, the apposition is very good. So I also prefer taking same size. Whatever I have done, the results were good. I feel that a step in may be better for epithelial, epithelium growing over the surface rather than step up of the host tissue, donor tissue. So that's what I felt.
Dr. Rajesh Fogla, you have anything to ask?
Well, I think Praveen has covered most of the points, and we are going to have another talk on use of microkeratome, because that is where people have confusion between using the ALTK versus using femtosecond laser. Sizing is more of an issue when you're using the microkeratome. With the femtosecond laser, yes, you can obviously go in with the same size graft. It is very important that when you are preparing your donor, you should not allow your donor to desiccate, because if that happens, then also you can have your graft shrink very quickly. And for the Zimmer that we use, instead of making vertical cuts, we made angulated cuts where the posterior diameter is larger than the anterior diameter. So what happens is, if I make a 150-degree cut and the posterior diameter is larger, my donor graft kind of goes into the slot. So it kind of much more secure once you have placed it without the sutures. So there, if you want, you can go in with a 0.1 millimeter larger. But then, as Praveen rightly pointed out, that even a 0.1 can sometimes feel like oversized, especially if your graft has been overhydrated. That means if you have kept your graft, prepared your graft, then put it back in the donor solution, it will absorb more fluid. Then it will not only thicken, but it will also look bulkier. So when you place it in the bed, you find that it doesn't fit very well. And yes, we always have the advantage of being able to do a subsequent refractive surgery to further refine the visual outcome.
Chitra, I had just one question for Praveen. That was Praveen, apart from Visumax, which you used for FALK, have you used any other machine, and do you think are there differences in the parameters of the two machines? Because I'm sure you've done it on multiple machines.
No, I've used the Visumax as well as the FS200, and now we prefer the FS200. Again, no financial interest, just because the fact that it seems as if the laser can blow through the scar a little more easily. The Visumax is a much gentler laser, and I think the laser energy is not enough for it to cut through scars that are dense, whereas the FS generally goes through scars more easily. I've seen this being done on other machines like the AMO. IFS also, and that seems to work very similar to the FS200.
Dr. Jagdish Reddy, do you have anything else to ask? Are you there with us?
Yeah, I'm there. So, yeah, no, Praveen has covered everything. Like, I do have similar experience using both Visumax and FS200. So, I think we do follow the same protocol of having the same size, and the results have been pretty good. Yeah.
Do you all have different configurations or always go for a straight cut with Falk?
No, we in FS200 you can customize, but we prefer doing it in the straight cut. That's what we've been following, and the opposition is pretty good, so we stick to the straight cut itself.
Thank you very much. We shall now go on to our next speaker, Dr. Vikas Mittal, with a 16 years experience in cornea and refractive surgeries, who's the director of LJI Institute, a very capable prolific surgeon, and he's going to be talking on manual dissection in DALT. On to you, doctor. Can you share your screen?
Yeah, I'll just share. Is it visible?
Yes.
Okay, fine. Thanks so much, first of all, Dr. Chitra and whole ARC team for this kind invitation. There was a beautiful talk on FALK, so we were in anterior stroma. So now I'll go if there's a lesion which is, deeper stroma, or where we'll do a DALK. And my job is to tell you how we perform a manual dissection DLK. And for this, I'll just take you through how I have learned this and how I generally perform it. For manual DLK, you cannot have any financial interest. So I started doing DLK close to 15 years back after my fellowship, and my first 6 DLK were 100% failure. So all 6 DLK I had to convert into penetrating keratoplasty. So at that time, I thought that maybe, I'm not a very good surgeon, or maybe this is not my technique. And I thought maybe then I started even trying to convince myself that PK is even better. I started telling myself that, if keratoconus, dystrophies, PK has very good results. So maybe I should do only PK. I shouldn't do DLK at all. And then I visited Baroda to Dr. Paras Ben Mehta and stayed there for a day in her clinics. And there I told her, Madam, see, the DSEC is easier than DLK. That's what I told her. And she said, no, Vikas, you can do it. You can definitely do it. And she showed me a few of her cases. And she says, you can do it. The only thing you have to do is get this bubble out of your mind. So the DALK can also be done without bubble. And then when I came back and started doing my manual DLK, where she suggested me that it's okay to leave 70-80 microns of posterior stroma behind, and you can go ahead with your routine DLK. And then I started seeing my DLK post-op, which was quite exciting. Although in the first couple of days, it was looking a bit hazy, but once this 1 month or later on, it was absolutely pristine. And I was feeling very good that, actually I can do a DLK. And with time, we started doing a large diameter or even PMCDs, advanced keconus, keratoglobus, and there was no need for a backup tissue. Initially, my DLK always I used to have a backup tissue. So here there was no need for DLK. And if you tell your patient DLK, I was sure that I'm going to do DLK only. So there was no reason that I have to explain that, maybe I'll have to convert it into PK. And there was no fear of perforation, as I said. And then there was no specific instrumentation that was needed. And that's why I think even now I'm continuing my manual DLK. And there's a recent publication from Dr. Fogla and Dr. Namta Sharma, and close to 1/3 of cornea surgeon in India or CSI members, they do manual DLK. So I think I'm one of those 1/3 surgeons. And why do they generally do it? If you see biomechanics in DLK, whether you do a big bubble or whether you do a manual lamellar dissection, it's same. And the visual results also, the astigmatism, best corrected visual acuity, once the switch is out, or 1 month later on, endothelial cell count, it's comparable, it's same. And in case you get into some problem, if you get to have a full thickness definition, the manual dissection DLK will be a big rescue. This is a beautiful article the beautiful review that I came across, who had reviewed all the techniques of DLK, and these are the complications that have been mentioned. And you know what? With manual DELK, there are no such complications that are possible. Emphysema, double bubble, perforation, double AC, these are almost rare with DLK. So majority of complications that has been described in literature are not possible with manual DLK. So what I'm going to do is I'm going to show you a video of how I generally perform the manual DLK, so that you can get a okay. So this surgery was done in a patient of keratoconus. So the surgery will be into 3 steps. First is host bed preparation, graft preparation, and then suturing. Let's take first host bed preparation. You need to choose a refined size so that you can include all the cone. Fleischer ring and topography map can guide you. So it is important, even if you take a larger diameter, it's absolutely fine. Fleringa ring, I like generally using Fleringa ring in all my keratoconus patients, but it's an optional step. The refine, it's very important to just make an impression. So if in keratoconus you keep refining and make a groove, then sometimes what happens is you end up cutting more of posterior stroma than anterior stroma. So you can have not a straight cut. So what I generally do is just make an impression, so that we know that what is the area that I'm going to dissect. And the grooving is done with a prefixed guarded blade. And here I'm using 250 microns. What I generally do is choose your thinnest pachymetry, subtract 100 microns from that, and that you can use 250, 300, whatever. So here there is a 360 groove, and the angle will be perpendicular to this area. So your blade will not be perpendicular to the visual axis, but perpendicular to the where your impression is, so that you can have a really straight cut. Once your groove is done 360 degree, you can catch hold of this anterior stroma and dissect it off. This is similar to what we do in any DLK technique. Here you can be very fast because it's quite thick and not very difficult. Important thing is to catch hold of the tissue flap near to the attachment, and then cut the fibers which are attached to the flap. This will be more important when we are cutting in second and third layer. So once the first layer is out, you make a decompression, and this air bubble, this fluid on the stroma and a dilated pupil, this helps a lot in seeing how much stroma is left over. So this is the layer number 2. Generally, you need to remove 3 layers. In 3 layers, most of the stroma is out. So here you catch hold of the thicker area. I generally like this upper and superior, this area, and then you first make you start dissecting all through, and then here you need to be slow. And what I'm trying to tell you is this: catch hold near the stoma and cut these fibers which are attached to the the flap, not the stromal bed. If you pull it, so you should not pull. You just simply need to just have a small pull, and then cut these fibers which are attached to the flap, so that the chance of perforation are minimal. Again, a fluid drop will tell you how much stroma is left over. So this is the third or the last layer most of the times. And when you are reached the posterior stroma, you can actually peel off these fibers. So you don't even need to, cut, but you need to be careful. You need to be slow. And you can see here, these fibers can be easily peeled off. So that means that you are nearly in the posterior stroma. Again, you can place a fluid and drop, and you can have an idea how much stroma. So this is my host bed is prepared. So next would be preparation of your graft. Graft preparation is, you can choose the disparity. Generally it's 0.25, but if it is advanced keratoconus, large defined, it's okay to use same size donor as well as graft. So you can punch the graft first and then you remove DM, as is done in this case. You can use a Merosol sponge. And if this tissue is old age tissue, the removal of DM is very easy. But if it's in a young patient, tissue, then sometimes it comes in a piecemeal. But it is important to remove all the DM and any epithelium, as you can see here. You can remove the DM first and then punch also. So in this case, you can remove the DM the way you do it in your DMAT. So you can punch anytime. So next would be the last step would be suturing. Pattern of suturing, you can choose whatever suture is. Suturing technique works best in your hands. I like interrupted sutures. So I'm using 10 on nylon. I'll make 16 interrupted sutures. Here, the difference from penetrating keratoplasty suturing and DLK is here I'm not going to keep 90% depth in the donor. So I'll take 50% depth in donor and are close to 70-80% in the host tissue. So it's important that you be aware that there is a DM down there, and you can you can puncture if you are not very careful. Suturing is very important step because the astigmatism and all those astigmatism will be mainly done by these good suturing. So here what I'm doing is pushing these folds into the periphery. I generally start doing this massage after 8 sutures. So from the center to the periphery, so most of the folds that are because of the excess stroma, so that gets pushed off into the periphery. So the sutures are buried in the graft, and then you just have a look with your Malny's ring to ensure that you get a good circle, as you can see here, and then the surgery is over. Remove your flaring ring, place a bandage contact lens, and that's it. So this is how generally looks first POD looks like. And you can see the first post-operative day, 77 microns, 42 microns. So it hardly matters if you have 42 of 70 because 77 microns, because once 2 or 3 months down the lane, you can hardly see your remaining tissue. So there has been a few publications where penetrating keratoplasty has shown a better visual outcome, and it's mainly because if you leave thicker stroma in that residual tissue. But if it's very less, then it hardly matters. But once all sutures are out, it's very difficult to see where your residual stroma is. So you can see 1 year, 2 years down the lane. So overall, so no need for backup tissue. DLK means DLK. No perforation, no special instrumentation is needed. So actually bubble got out of my mind, and even after 15 years, I'm still following my manual DLK. Thank you so much.
Thank you very much, Doctor. That was an amazing talk to hear and very practical tips. I just have one question to ask before I hand you over to Dr. Rajesh Fogla for more discussions. If you've had an unsatisfactory BCVA post-DAL, how long would you actually wait before you decide to convert to PK?
So that depends that what is the reason for unsatisfactory visual outcome. So most of the time, unsatisfactory visual outcome is because of the astigmatism. So if that you need to address why that astigmatism is more, whether it's a sutures problem. So you can have the interrupted suture is very good that you can later on also you can remove your sutures. Generally, if you get a really weird astigmatism within first month, it's better to remove those sutures and place a new sutures. Otherwise, your routine astigmatism management that we start after 3 months. So most of the time it is because of sutures. So I haven't seen any patient where the visual outcome is less because of the interface and interface haze. There was a couple of patients, I think, where you have a bad surface and you have to do DLK for some other reason. There you can get an interface vessels. That is the only area where you might have to think of doing converting into PK. But again, those will be very high risk grafts, and you need to take care of immunosuppression as well.
Dr. Rajesh Fogla.
Yeah, Vikas, nice presentation. From what I understand, you indicate that you are not doing any more big bubble talcs.
That's right. I don't do any big bubble talc at all.
Yeah, but that I think is again a little extreme, because selective cases, big bubble talc definitely gives a better visual outcome, both in the terms of the rate of visual recovery and the number of percentage of patients achieving 20/20 or more. And if you select, at least in my practice, I rely more on the anterior segment OCT. And any cases where the pathology is involving the predecimus layer or the decimus like a scar, then I avoid any stromal injection of air, because that is going to have an abnormal outcome of the air injection. And in such cases, doing a manual talc definitely is recommended. And in your surgical video, you were doing all your dissection using the same sharp crescent, or do you modify the instrumentation?
Yeah. So generally the first, second and third layer will be a blunt crescent, a used crescent, and the first will be the same, the prefix depth and the same one. And if I have seen my big bubbles, the initial ones, and the manual DL, somehow I found that if you have these 50-60 odd microns stroma left over, you can't even make out even in the OCT later on. So I think the main difference in visual acuity would be in the first month, or maybe first two, three months. But later on, what I have found is it's same. But I agree, the big bubble DLK is also extremely good technique.
Yes, because I think the key point that you made was having a residual bed which is going up to 60-70 microns. But for somebody starting out with DALK surgery, how does one, recognize that they have only 60-70 microns, unlike you have an intra-op OCT like what Dr. Namrata has? It may be sometimes a little difficult. So what are the tips on recognizing? Is it just multiple layers of dissection, or is there anything else that you would want to?
So what I generally, we don't do any intraoperative pachymetry. So as I said, if you have a dilated pupil and you place a drop of fluid, so you get a hang of it, that how much stroma is left over. And in case your central part is around 50-60 microns, and in the periphery, even if you have a thicker one, it hardly matters. So it's the central part, but what I found is more important. And how do I see how much thickness of I have reached that thickness is just after doing got a hang of it, that how much stroma is left over. And then, as I said, that if you start reach a layer where you can easily peel off these fibers, so that means that you are already in
Can I just make a comment here, Chitra? I think when we didn't have intraop OCT microscope, we did describe, and Dr. Vajpayee described a technique of diamond blade assisted deep anterior lamellar keratoplasty. So if you have that, then you can actually do a intraop pachymetry without having a OCT microscope, just a ultrasonic pachymetry intraop at the level where you're going to dissect, and preset your diamond blade to minus 80 microns. And what Vikas is saying and what Rajesh also says is perfectly correct, because there is a paper, if you see, almost 5 to 6 years ago, which has compared DALK, where the residual bed thickness was to the tune of 80 microns versus DALK, which was just desmetic. And they said that if you leave 60 to 80 microns thickness, it really doesn't make too much of a difference in terms of visual acuity or in terms of contrast. Although today probably we will not go by that, and still we will tend to think that if it is desmetic, then the best corrected visual acuity and the contrast sensitivities are going to be good. So I think if you have a diamond blade, then you can always preset to that and make a groove, and then try and get that thing. Although I do believe that in keratoconic corneas or extreme ectasias, it will be a difficult thing to do, to get that same level over that bulge which is there.
Sometimes you tend to have at the apex, especially in keratoconic corneas, you will find that at the apex or at the thinnest point, you are down to about 30-35 microns. But if you go to the periphery, you will find that you still have 100-110 microns remaining. So the question then comes is the graft-hole junction apposition. So if you're taking a full thickness donor and opposing it, while the sutures are in place, the graft-hole junction looks quite flat. But once you remove the sutures, you have a kind of bulge at the graft-hole junction in the periphery, which then kind of induces aberration. And often you find that in such patients, once you do all the suture removal, often there is a drop in their quality of vision because of this change in the corneal topography. So for that, I think Massimo Busin has shown a technique where they use the anterior cap from the DSEC surgery. So their grafts are only 400 microns in thickness. And for manual DALK, they place the 400 micron, and that gives a better apposition of the graft-hole junction.
Thank you very much. We'll have more discussions as we go on. I will now introduce our next speaker, Dr. Shrish Kumar, who is a medical superintendent of the Eye Foundation Group of Hospitals, with a rich 21 years of a great caliber with innumerable publications and tips to achieve it. On to you, Dr. Shrish.
Thank you, Dr. Chitra. At the outset, I would like to thank ARC for the opportunity. And my topic is big bubble technique for DALK. So there are many surgical techniques which has been described by various authors for stromal separation, and it was actually discussed by Praveen also and Mithal. So the fastest and the safest method to reach desmids is a technique called big bubble technique, which was described by Anwar and Cheekman. And here the cleavage plane is between the stroma and desmids membrane, or stroma and the Duas layer. And it's called the big bubble DALK. The procedure is called big bubble DALK. And it's well known that when the air is injected into the cornea, corneal stroma, there are three types of big bubbles can be achieved. Type 1 big bubble, it's also called white margin bubble, which is the most common type, and the cleavage plane here is between stroma and the predesmatic layer or the vas layer. And type 2 bubble is the bubble which has a clear margin. You can see here the clear margin, and it forms between predesmatic layer and desmids membrane. And the type 3 bubble is a mixture of these two, type 1 and type 2 bubble. So I'm just going to demonstrate a few cases of a type 1 bubble formation. This is a case of keratoconus. You can see a white margin bubble is formed. This is a typical big bubble type 1. And this type 1 bubble is achieved in almost 80-85% of the cases. And this is the preferred type of bubble in DALK, as even you are preserving Duas layer, which gives added strength to the desmids membrane, and the chances of perforation or rupture of desmids membrane becomes less if you have a type 1 big bubble. Here the formation of big bubble, it starts the small white emphysema in the center and extends to the periphery. And you may get it in one go, or you may have to inject air in several locations. There is an emphysema in the periphery, and now with the second injection, I am able to achieve a big bubble here. You have to just change the site of injection. Or the air can escape to the periphery and to the center simultaneously. You have a nice big bubble here, but the air has escaped to the periphery. It doesn't matter. And it's an easy way to identify the formation of big bubble is by injecting air bubble into the antechamber. You can see the movement of this bubble in the antechamber with the formation of a big bubble. There is a big bubble type 1 is formed here, and it has displaced the air bubble in the antechamber to the periphery. So the surgical procedure, once a big bubble is achieved, I usually do a superficial lamellar keratectomy using a crescent blade and a lymph forceps, and with the 11 number blade, I make a bold nick incision and inject viscoelastic substance through this nick incision, just to keep desmids away from all the manipulations. And the posterior lamella is excised using 1R scissors, and the posterior lamella is cut into 4 or 5 segments, and each segment is completely excised and taking care not to leave any posterior edge. This is the donor preparation. Just scrape off the donor endothelium, desmids complex, and give a thorough irrigation because you have used viscoelastic substance, and then place the graft over the host and suture it to the host. I usually use 16 sutures, 10 monofilament nylon. If the graft is bigger than 8 millimeters, if it is less than 8 millimeters, we can use 12 sutures, interrupted sutures. This is a case like every time you may not get the right steps. Like if you see here, have a nice big bubble. I'm just doing a superficial lamellar keratectomy. I'm just trying to uh, puncture the bubble, but I could not. And then I went ahead with the second dissection. And now I could achieve a clearance till desmites. Another case of keratoconus, just injecting a bubble in multiple sites, but still I could not get a big bubble. It's just an emphysema of the cornea. That's the white opacification of cornea. Go ahead with the superficial lamellar keratectomy. Once the debulking is done, I inject air, and now this time I could achieve a big bubble, but I could not collapse the bubble. I was not bold enough to collapse the bubble. Maybe in the initial stage of your learning of this lamellar keratoplasty, it's better you collapse the bubble in the periphery, so you can go layer by layer, a manual dissection from the periphery, and try to collapse the bubble in the periphery. So I'm just collapsing the bubble now, and then inject visco, separate the posterior layer of the stroma. And suture the host tissue, donor to the host tissue. Coming to type 2 big bubbles, as we have learned, it is between desmites, and you can just observe this. There's a thin walled bubble which is formed here, which usually happens in patients with scar, corneal scar. I usually do a layer by manual dissection. And in spite of having a big bubble here, I usually go ahead and do a manual dissection because type 2 bubble is more prone to rupture. And you can do a descemetic DALK, a pre-descemetic DALK, if you achieve type 2. It's very important to observe these bubbles. Many times you may not be able to observe type 2 bubble. If it is associated with type 1 bubble, you concentrate more on type 1 bubble only. Another case of type 2 bubble formation. The classical teaching is type 2 bubble forms from the periphery, but here you see it is forming from the center, and it's a thin walled bubble. It's not a very big bubble. Usually you can achieve up to 10 millimeters, 10.5 millimeters of diameter, but this is around 8 millimeters. It's a type 2 bubble. Another case of type 2 bubble is a keratoconus. Is a reasonably large bubble, which is around 9.5 millimeters. It's a thin walled bubble. It tends to rupture with manipulation. And a case of mixed bubble. There's a small big bubble which is formed. There's a small type 1 bubble, and carefully if you observe here, there's one more bubble forming behind this small bubble. This is a type 2 bubble which is formed here, and it's a mixed bubble or a combined bubble, that is a type 3 bubble. It's a very interesting case. It's done almost 10 years back. Since it has some educational value, I just wanted to show it here. Carefully observe this. While injecting, there's one big bubble formed here and one more bubble. There are two bubbles. One more time, since it's not very clear, I just wanted to show it again. So one bubble is going to form. Yes, one bubble now, and the second bubble formed. Both are almost a large sized bubble. It's not partial bubbles. It's a type 3 bubble which has formed here. The same patient, after dissection, I could reach up to desmites but there are some fibers or debris on the surface. This is a Duas layer. It's not necessary to separate it. It's actually ideally you can leave it. It gives adds strength to Desmids, and that too using the sharp instruments like this is not at all done. It should not be done actually. We should not separate this Duas layer. It will not change the BCVA. And so far, so good. But if you see in the next step, I try to remove some debris, the DM ruptures. It's a big tear. It is a white to white tear, almost a full extending from one limbus to other limbus. So you have to convert it into a PK. And the difference between type 1 and type 2 bubbles, so the anterior surface is actually in type 1 bubble, it is not very clear. You can see broken strands of fibers of collagen. And the surface is a rough looking surface, whereas in type 2 bubble or in type 3 bubble, the anterior surface of the Desmids membrane is exposed to creation of type 2 bubble here. And the surface, it is very smooth and it's featureless with no visible fibers on it. And this type of bubble is actually more prone or susceptible for rupture. This is the last video. This is a case of advanced keratoconus wherein I was actually planning to do a manual layer by layer dissection. If you see here, like there is a healed eye drops case. There is a perforation happening because of the irregularity of the anterior cornea here. There's a perforation. It is right in the center. And if the perforation happens right in the center, it's better we convert it. And if the dissection is not complete, definitely it's better to convert these cases to penetrating keratoplasty. You can see it's quite a big tear. So this can happen in a manual dissection, but more or less big bubble technique is very safe. And here it appears to be the best surgical approach for a DALK. When the surgical goal is to reach the plane of Duas or Desmids membrane, visual outcome will be much better as compared to manual DALK. And we can always achieve a visual result similar to penetrating keratoplasty in a big bubble DALK. And dissection can be considered if there is a complication or intraoperative perforation, or or as an alternative to big bubble technique, we can do a manual technique. But big bubble technique, the surgical outcome, visual outcome is much better. I prefer big bubble technique over manual dissection. Thank you.
Thank you, Dr. Shreesh, for an amazing set of videos. But we've crossed time a bit, so I'm going to ask Dr. Rajesh to just take one question. Dr. Rajesh Fogla.
Yeah, I can ask Dr. Tityal if he is around to give some tips on, big bubble technique, whether he does it in all his cases or selective cases.
No, Rajesh, I think all the big corneal surgeons are present today, and I think young people are going to be listening to us. My only humble request to a younger generation is, acquire OCT-based microscopes if you're going to be a future cornea surgeons. I think that is a necessity for our cornea surgeons. So people have to invest on that, because the visibility of surgical steps intraoperatively is the key factor for success. So whatever video we have seen, are nice videos. We have made so many other ways to assess the formation of big bubble, like a double bubble techniques, or people describe various key features of a big bubble formation. But at today's generation, I think people would have to shift on that as far as future is concerned. But yes, what Vikas showed and series showed us, things can be done without OCT microscopes also. But I think it is a necessity. I think Rajesh agrees on this.
Thank
I
you.
agree with you on this, sir.
No, I'm pretty sure if I leave API center, I may not be able to acquire those. But for the younger generations, I think they have to think on this. If they think now, definitely they'll acquire these because all microscope in future is going to be OCT attached.
We shall now go on to our next speaker, Dr. Sujata Mohan, Associate Medical Director of Rajan Eye Care Hospital and a specialist in anterior segment surgeries. As a director of Rotary Rajan Eye Bank, she has performed innumerable eye transplants. Again, she has had some of the most amazing sets of awards and accolades to her repute. The list is too big to enumerate now. And let's hear an interesting debate between her and Dr. Parul Deshpande. Dr. Sujata is going to talk about favoring DALK in post-eye drops. On to you, Dr. Sujata.
Thank you, Dr. Chitra, and thanks to the ARC committee for giving me this opportunity. So my topic is on DALK in acute eye drops. So will I do it? So I'm just going to show you a case report of a 25-year-old female who had an advanced keratoconus and underwent DALK 1 year prior to this case. And she was doing very well. So she was avoiding surgery for the other eye. And she had quite an advanced keratoconus in the left eye. Then she came one day with a sudden onset of pain, watering, and complete loss of vision. And you can see the ASOCT showing definite break in the descimits and clefts in the stroma, stromal edema as well. The diagnosis of acute eye drops was made. And we medically managed her for about 1 week to 10 days with topical steroids and hypertonic saline, oral dorzolamide, and lubricants. But she was very uncomfortable. She had a lot of irritation and pain. And so decided to do a little bit of surgical management and injected air into the anterior chamber. We waited for 3 days. There was no response because the air got absorbed within a day. And she continued to complain. So I decided to give a C3F8 non-expansile gas injection into the anterior chamber. And I combined it with a venting incision to remove the stromal fluid so that the edema will resolve quickly. So you can see there is definite reduction of edema on the first day post-op. And the anterior OCT also showed the closure of the cleft, the desciments cleft, and the edema is significantly reduced. However, the third post-op day, again, the edema started forming and increasing in size. And you can see the break in the desciments once more and the fluid clefts in the stroma. And by 1 week later, you can see that the whole eye drops has become much bigger than the day of presentation. And you can see very large fluid clefts and very large area of desciments membrane opening. So the corneal edema showed that had increased, as you can see from the first picture post-op. And the ASOCT also showed quite a large area of desciments break. And there was just a little bit of Bowman's membrane and epithelium remaining. So there was a possibility of impending perforation. So we decided to go ahead with a DALK. And this time, obviously, only a manual DALK can be done. So just to facilitate the dissection, we normally inject, particularly any patient we do a manual DALK. I like to inject air just so that the stromal emphysema will allow me to dissect more carefully. And this patient had about a 9 millimeter host definition done. And once stromal emphysema was created, a manual DALK was done with using a 15 blade to start with. Once there is a perforation in the DM, the very important thing that we have to remember is that if you're going to do the regular type of dissection and do a superficial keratectomy from one end to another, you're likely to go across to the area of perforation, which can actually extend. So it's important that you go all around and then come to the area of perforation as a last resort. And the superficial keratectomy is continued. You can see with the crescent knife as well. And we were able to dissect most of the stroma. And this is the last area where we are close to the perforation and it was removed using a minor scissors. And deep manual dissection was again continued using the crescent knife till as much of posterior stroma as possible, which was visible to us and what was possible to do without too much of air escape, we managed to do it. And once we came to this stage, I decided to stop and used the same 9 millimeter graft foot suturing. And this is a intraoperative picture, and this is a post-operative 1 week post-op picture. You can see some amount to this area of perforation, but the patient really was very happy because her visual acuity improved from PL to 618. And you can see the stroma, there is some amount of irregularity in the stroma on either side. There's a residual stroma, but in the area of perforation, it is almost absent here. So the question is whether that should be considered as a first option. No, definitely not, because most patients respond very well to C3F8 or even air injection. In this patient, we had a widening of the cleft with impending perforation, and somehow I was not very happy doing compression sutures at that stage. So I decided to do a manual DALC. The other option is you can do an ultra-thin DSEC and DMEC, and there are reports of this which have shown excellent response. Because basically what you're doing is you're covering the gap, the cleft which has been created. And then once the endothelium gets populated, then the edema resolves. So the advantage of doing DALC in the acute phase is correction of pathology by closure of the DM, and anatomical correction of the ectasia as well. And refractive correction is also better because there's an improved corneal topography. The patient is able to see better. And regaining the corneal structure and transparency in one go, and retention of the host desmids and endothelium. However, there can be some disadvantages, like operating on an inflamed eye, the risk of local anesthesia in these patients, need for expert surgical hands. You should be a good lamellar keratoplasty surgeon. And also the potential risk of perforation extending, so you need to have a good tissue in reserve. And the most importantly, there can be residual stroma which can interfere with the vision quality. So I would like to close my talk saying that whenever you find yourself in the side of majority, it's time to pause and reflect and think if you can do something differently. These are some of my references. And once again, I'd like to thank Chitra and the ARC for the wonderful opportunity. Thank you.
Thank you very much, Dr. Sujata. Let's hear Dr. Parul before we go on to some discussions. So Dr. Parul is going to say no to eye drops. And she's again specialized in cornea, cataract and refractive surgery, a very astute surgeon with a great presence in Mumbai. On to you, Dr. Parul.
Thank you, Dr. Chitra. I'll just share my... Yeah, so can you see my slides? So are my slides visible?
Yeah, yes, it's visible.
Okay. Thank you, Chitra ma'am. Thank you, ARC, AIOS for giving me this opportunity. So far we've heard from all the speakers that how wonderful is a DALK procedure, especially in patients with corneal ectasias. However, in some of the cases of post-eye drops, complicated cases, it may not be the ideal procedure, especially for a novice surgeon or an inexperienced surgeon. So corneal eye drops, as we know that it occurs only in 3% of the cases, it resolves usually over a period of 2 to 4 months, and it leaves behind a corneal scar, which usually hampers the visual acuity. These patients, however, can be improved with the contact lenses, but some of the patients still would require a corneal transplant procedure. So which procedure? DALK, as shown by Dr. Sujata Mohan, who's an expert cornea surgeon, or penetrating keratoplasty. So I would just try to prove some of the facts, clarify some of the facts while deciding to go with DALK or penetrating keratoplasty. So this is one of the articles. It was a retrospective study done by Basu and Reddy et al., where they have looked at 5 years outcome following penetrating keratoplasty in cases of resolved eye drops. And they found that the outcome, long-term outcome, as well as the visual acuity, despite having a higher rate of endothelial rejections, was excellent. So some of the factors that we need to look at when we are managing a post-corneal eye drops is corneal scarring. So if there is an extensive amount of corneal scarring, which is involving the desmids membrane, and if it's centrally located, it is better to do a penetrating keratoplasty and not a DALK. So this is one of the patient. The left-hand side is the acute eye drops picture, and the right-hand side is the resolved eye drop. And look at the amount of scarring which is present in the deeper stromal layer as well as the endothelium. So this patient probably would do better in terms of better with
penetrating keratoplasty if we are looking at better visual outcome. I can't. Okay. So in contrast to this patient where you can see the paracentral corneal deep scar, but it's not involving too much of the Descemet's membrane. This patient probably would do better with DLK in a normal surgeon's hand. Second thing that we have to look at is the health of the corneal endothelium in these cases. So it's been seen that the post-hydrops cases, the corneal endothelial cell density remains good in majority of the patients, but about 20% of the patients still will have 15% or more drop of the cell count. Besides, the morphology usually gets affected in most of the cases of acute hydrops. The second thing is that when we compare a long-term visual outcome, as far as the endothelial cell loss is considered with DALK and penetrating keratoplasty, it's been seen that an uneventful case of DALK without an intraoperative corneal perforation has a much better endothelial cell count at the end of 1 year when compared to penetrating keratoplasty. But if you have an eventful DALK with an intraoperative corneal perforation, the endothelial cell loss is equivalent in both DALK and penetrating keratoplasty at the end of 1 year. So as Dr. Sujata Mohan has already discussed that we need to modify the technique of surgery in these patients. We need to do a manual dissection. In event of dissecting, it's important to leave the area of thinning the last, but one may sometimes leave behind a greater amount of residual stroma in order to avoid the macroperforations. So in these patients where you are performing a DLK, you always have the scare of perforation, and hence one has to always keep a good quality donor tissue. And it's important that one performs this procedure under general anesthesia, as we are likely to take a longer time. So cases where we may not be able to take general anesthesia, probably PK would be a better option. And when we look at the visual outcome, it's been seen that a DLK procedure performed with the residual stroma more than 20 micron, usually the visual outcome is subnormal and it is not equal to what we achieve with a big bubble DLK or a penetrating keratoplasty. So with this, my indications for penetrating keratoplasty usually post-hydrops are cases of severe hydrops with large Descemet's membrane tear, which is more than 3 millimeter width, as you can see in this photograph, or when there is an acute perforation in cases of acute hydrops, or there is a persistent chronic edema, which indicates some amount of endothelial dysfunction, or when you have a dense scar in the visual axis, or you've encountered an intraoperative macroperforations and you will have to resort to a penetrating keratoplasty. Those cases which are high risk for general anesthesia, probably I would avoid a DALK procedure and I would head to a penetrating keratoplasty. And the last indication being the associated endothelial dysfunctions, which are present in patients with keratoconus, like in this patient where there is a PPMD coexisting with the keratoconus. So probably I would resort to penetrating keratoplasty in these patients. So to conclude, DLK definitely yields good visual outcome in all cases of keratoconus, but it definitely demands high surgical expertise, especially in advanced cases as well as cases with hydrops. And PKP has a good visual recovery. It has a good long-term survival in all cases of keratoconus, despite having high risk of ejection. So with this, I conclude. Thank you.
Thank you, Dr. Parul, for all your strong counters. I just wanted to ask Dr. Jagdish Reddy, what tips would you give for suturing to our attendees if the host trim gets quite thin, which is likely, if you're doing dark in hydrops? Can you stop sharing? Oh, you stopped.
Yeah, sorry, ma'am. Yeah.
Yeah, so I think it's very important to look at you involve the entire cone. So if you do have a thinning in the periphery, that means you do have a part of ectasia still left over. So I think it's very important pre-operatively to look at the extent of the cone and using a slit lamp examination and marking on slit lamp examination the extent of cone and looking at the topography as well. And on table trying to remove everything, you may not have difficulty while suturing. But if you have some amount of ectasia still in part of your trephination, you're going to end up with thin cornea in that area that may cause difficulties. Usually with keratoconus, we don't face much problem in suturing, but you do encounter an issue with PMCD, wherein you have inferior thinning and keratoglobus. That could be one of the situation where if you get mistaken by that it's a keratoconus and try to do a keratoplasty, wherein you would have various lot of difficulties during suturing.
Dr. Bhaskar Srinivasan, I want you to ask you, if it is a situation where there are deep vessels which have happened in eye drops, or if there's an allergic eye disease, in those situations, would you still prefer to suggest PK for eye drops?
And so basically, when you're looking at an option between PK and DALC in a high risk situation, I would probably want to err more in terms of a DALC rather than a PK to begin with. The issue is if it's a post eye drops case, you might not be able to bear the DM. So you might actually sometimes end up having sutures getting loose faster. You might end up having vascularization tricking into the interface and such. But if it's a very vascularized or an allergic eye disease, and most of these eyes will probably require a much larger graft, 8.5, 9 or 10. So if you're doing a large graft, hot bed, uncontrolled allergy, these are all factors where the risk of rejection of a PK is going to be higher. I would prefer to do a DALC. If the haze in the center doesn't give me a good visual recovery, I can always go ahead and do a central 7mm or an 7.5mm PK subsequently, which is at least limiting my allogenic tissue more to the center away from the vascularized periphery.
Thank you very much. Dr. Rajesh Fogla, anything to add before we go on to our next speaker?
I think both the speakers have valid points among the cases that they have discussed. But in my practice, if we see eye drops, we always try to medically manage by either using compression suturing combined with gas bubble in the anterior chamber. Because in majority of cases, once the eye drops resolves, the patient's visual acuity also improves. So you can get away without doing a corneal transplantation procedure. And also, surgery also becomes easier when the corneal edema has resolved. You can do, even if you are doing a manual DALC, you can achieve a much better dissection plane and give much better outcomes. And often you may find that the diameter of the graft that you require will be smaller when the edema is resolved. Whereas in the presence of edema, you will have to go and choose a much larger diameter because of the edema that's occupying the central or paracentral cornea.
Thank you. So we shall now go on to our next speaker, Dr. Namrata Sharma, who's going to tell us how does intraop OCT refine managing complications of lamellar keratoplasty. On to you, Dr. Namrata.
Thank you, Chitra. So I would be talking to you about how does intraop OCT help lamellar keratoplasty. And I would like to thank ARC, especially Dr. Chitra, for this opportunity. And having heard the talks before on DALC and also DALC in acute eye drops, I think things have become simpler. So all I need to do is just point out on what would happen on the intraop OCT microscope. So basically, when you have an intraop OCT microscope, you know the level at which the needle is there. So you will not cause any perforations. The air bubble can be seen by the Descemet's membrane, which has fallen back. And when you give a nick in the overlying stromal layers, you can actually see the overlying, the Descemet's membrane, which is going, you know, like a live image going towards the overlying stromal layers. Then subsequently, when you put the viscoelastic again, you can see that it goes down just like a kangaroo's pouch. And the important thing or the highlight of this is that you probably don't need a slit lamp, and this OCT is always attached. Not that you can't do DALC without it, but it just helps you to refine your surgical steps better, and you are more sure of things. So this is the bare Descemet's membrane over which the full thickness donor cornea without Descemet's membrane is then sutured. And again, then you can also see whether it is tucked in on all sides or not, or whether there are any gaps which are present. Likewise, very nicely shown by Dr. Shirish, the type 2 bubble, which is coming from the periphery, coming right up till here. And then again, notice that the level of the needle can be seen at what level you are at 90% depth or 80 or 70% depth. And then sometimes notice how fast the, when you give a nick in the overlying stromal layers, how fast the Descemet's membrane entire complex would move, Dua's layer complex would move. Now there are actually two bubbles here. One is a larger bubble which is trying to extend, and one is a smaller bubble. And unlike the previous surgical video that you show, as soon as you give a neck, just see so fast it is. And the speed has not been, edited at all. So you can just put viscoelastic and again get your Descemet's membrane Dua's layer complex beneath or get it down and then do the surgery as was shown before. Now, sometimes the bubble collapses when you're, doing the surgery. And so when that happens, then again, one has to take care of that. Now, this is the nick which is being given in the overlying stromal layers. And again, notice so quickly it will move up and you can actually make out the gap between the Descemet's membrane and the overlying stromal layers. And again, whenever it gets closer to your stromal layers, you can actually push it back by looking at the intraop OCT microscope so that you are far, far away when you're doing the dissection of the stromal layers. Then when you do have a perforation, you can make out otherwise also, but notice just as a perforation is here and there's egress of the aqueous, you can actually see that there is a defect also in over there. And then you know that you can leave this little bit of tissue over here where the perforation is there, which acts like a valve or which acts like a self-sealing kind of a flap over there. So you can just leave that little bit of tissue there and then again go ahead so that you can do again a talc in this procedure without having to convert into a penetrating keratoplasty. Now, healed hydrops, I think it has a great role to play because you can see that there is a healed hydrops which is present at the level of the opacity. And notice that it is so desperate. The corneal thickness is thicker on one side, thinner on the other side. So this just helps you to shave everywhere equally so that you come onto the correct plane. And when you actually give the post-operative outcomes, you don't have to give disparate planes, which Dr. Rajesh was also talking about, 100, 150 microns in the periphery, and then up to the level of the Descemet's membrane in the center. So just as you come to the area of that healed hydrops, you go a little anteriorly so that you are above the area of the healed hydrops and your dissection is clear. And luckily this area, this is the cross section here, this area which is there is actually in the paracentral region, so will not affect the visual acuity. And like I said before, when you do have about less than 80 microns of thickness, the visual acuity is as good as you would do a descemetic DAL. In ocular surface disorders also, it is very useful. Again, layer by layer can be done, very nicely shown by Vikas. You can see actually by comparing it with the tissue which is left above it as to what is your level of dissection. And then when it gets clear, then one can suture the cornea onto the host. Now, again, very useful when you have a Descemet's membrane detachment and double chamber in the post-op period, for instance, in this case. And when you put air bubble, you actually can't, you've still not got it attached. But if I didn't have this IOCT, I would think I'm done. But actually, I'm not done because there is a gap there which needs to be addressed, which you can only pick up on the OCT. So intrastromal drainage from the top is being done, and notice the gap has decreased. And then put air bubble again, and the gap would disappear. So now I'm completely done. And this is the, this is the way in which the IOCT helps you to fine tune the picture. Now, coming to a little bit of DSEC, IOCT guided DSEC, very elegantly described by Dr. Tityal sir in his paper when he published the first few cases that we did on intraop OCT microscope. Very useful for cases like ours, which have hazy corneas. So sometimes you don't know where the graft is. And then you can, on the intraop OCT microscope, see that it is there in the anterior chamber, put an air bubble there. And again, if I didn't have the microscope, I would think that there are no gaps present in between, but there are actually gaps present in between at the microscopic level, which need to be addressed. And as you actually hydrate the wounds, you can see the graft moving. So again, that needs to be, the end point has to be reached. Now, sometimes you have very thin grafts and you don't know in ultra thin DSEC whether it is upside down or not. So look at the configuration of the graft. Now this is absolutely upside down. And when the configuration of the graft is like this, which is along the cornea, then you know that this is endothelial side up. So this can happen in hazy corneas with very thin grafts, which are being addressed in the anterior chamber. Now, again, I think for us, it is not such a big issue, and we probably don't need a intraop OCT microscope to fashion the Descemet's membrane roll, because everything is so nicely visible by the trypan blue dye. But sometimes there may be adhesions or micro adhesions present between the Descemet's membrane and the overlying stroma, and then it might just help. So this is just S-shaped, how we mark S-shaped onto the corneoscleral rim so that we get S-shaped onto the graft. And look, it looks actually, the beauty of it, it looks almost like a desmetoseed. So you just put the lid over there. And important thing is that you remove the Descemet's membrane again, and then get it into the Petri dish and load it in the manner in which it should be in the eye, so that you don't have to change the orientation. Again, when you are doing a DMEC procedure, it helps you to get rid of the tags which may be there, which may otherwise not be visible, especially in the hazy corneas again. And when you put the graft inside, you have to get that biceps curl upwards. Now, this is a totally upside down graft. So you have to put fluid there so that it gets the biceps curl upwards. This is the correct orientation. And there is no S-shaped stamp here, because this was the very first case that I did of DMEC, and at that time we didn't have S-shape. We didn't think of S-shaped stamp, and you know that the graft has got stuck to the back of the cornea, and this is in the post-op picture, which looks very clear. Then in hazy corneas, again, extremely useful because of the fact that you can't see anything. This has a S-shaped stamp, the graft, but notice that the cornea is so hazy, and you can see this tightly curled up roll here. You can't make out where S is in this. So all you have is the intraop OCT again, which helps you. This is the biceps curl upwards. So both the biceps should curl upwards like that, and then you just tap, and get it in the correct orientation. And this is absolutely correct orientation, and you can't see the S here. So this again comes to your rescue. Now, sometimes there are folds in the DMEC graft such as this. Now, the folds in the DMEC grafts are absolutely different from folds in the DSEC graft. Now, your DMEC graft is absolutely okay, and then notice that there is a fold here which is present in the side. So you can't go beneath the graft, you have to go above the graft. So you go above the graft, put some fluid over there so that it gets unrolled, which again can be seen on the IOCT that it has got unrolled, and then get the air bubble, and the right S is staring at you with no fold at all. So you know that you have finished the surgery with the correct orientation and the folds which have disappeared. A very short video to show that in cases of eye syndrome, you can see the iris adhesions. Not a big deal, because you can see the iris adhesions otherwise also on the microscope. Only probably it helps in these cases is that because when you're putting the graft inside, again, it's got a little bit hazy here. So it just tells you whether you are in the correct direction or not. So this is the post-op picture. And this again is the last video which is shown here, where there is a failed DSEC which is there, and we used to do DSEC only, but then DMEC came into vogue, and so we thought for this is what I was telling you, you put it in that direction or in the configuration into your injector in the way you would want it to be in the anterior chamber. So what would happen is that you wouldn't have to tap it too much, and you would still be able to get the biceps curl upwards, and then put air bubble there so that the graft gets stuck in the right direction. So to conclude, I think intraoperative OCT is a useful tool. It is a third dimension. It adds third dimension of the corneal layers. It's like a third eye, and it just refines DALC and DMEC and DSEC and helps to see the unseen. But of course, the modification quantifications are required for current system for accuracy. And also, I think the companies, which Dr. Tityal sir was saying that everybody should buy it, I'm sure the companies are going to come out with more affordable options. And this can then be maybe just an attachment on any microscope, which can be taken up by, people who will not be able to afford such highly priced intraop OCT microscopes as of now. Thank you very much for your attention.
Amazing presentation, Namrata, as always. But we'll come down to what our attendees also would need, because intraopacity, I'm sure all of us can't have. So I'm going to ask Dr. J.K. Reddy. Are you there? Dr. J.K. Reddy? It's not there. Rajesh
Yeah, I am here only. Yes.
I'm going to ask question to all
Yes,
of any
I am
of
here
you.
only.
A simple, straightforward question. If you have a double anterior chamber, how long can you, Dr. J.K. Reddy, how long can you wait? How soon should you intervene?
Usually double
You heard the
anti-chamber we
question,
interfere.
Dr.
Yeah. We generally do it in first post-operative visit. That is after 1 week, usual double anti-chamber. Now we came to know that inferior PI will solve the problem of a pupillary block. So we do an inferior PI and tighten the chamber in the first hour. We don't wait for a long time, because sometimes wait for a long time, you produce some amount of stromal edema, which we don't want in a case of keratoconus. We want as clear corneas as possible. In the initial days, we used to wait for some time and see what happens, because we are worried about people who block and up. Now we immediately take it up for surgery. And do we have OCT? We don't have a intraoperative OCT, so we do postoperatively OCT the day, same day, and next day. Then it settles down well.
Dr. Rajesh, could you take the
Rajesh, you'll have to take it up. I think Chitra's.
Okay, I think what she was asking was Rajesh Sinha for his comments on the same question. If you have a double anterior chamber post dark, what your option manager? Rajesh is there, maybe he can give his comments.
I think
he's also not there. Then we can move on to the next talk by Dr. Rishi Swarup, the director of Swarupai Center in Hyderabad. Dynamic.
Can I make a small comment, Rajesh?
Yes, Dr. Titial, please go ahead.
Yes,
regarding double chamber, sometimes you are lucky that it is the initial phase of double chamber. That means the descemet is not very far off from the host stroma, or it's not complete detachment. The difficulty is when you have a complete detachment. Sometimes what happens, people inject air bubble towards the end and it goes in the interface, and the entire descemet lies onto the iris surface. So that makes life very difficult to really inject your needle or place your needle underneath the descemet membrane. And there, I think the role of either the technique we've described, a double bubble technique there also, to realize that if you have a two bubble, create a two small bubbles, so you know that you are underneath the descemet membrane. Or an IOCT microscope, which we discussed, we may not be there with everybody. So it is very important to assess the amount of descemet detachment. Is the depth of descemet detachment totally, and always try to inject your air or a gas from an area which is attached, away from the detached area, so that you can do it better. Just highlighted that point.
I think very valid points. I think it's also important to identify the etiology why you have a double anterior chamber as well. It could be because of intraoperative break that you have had, or it can be because of retained viscoelastic in the interface itself. And the other technique of doing it is you can even do it on the slit lamp, the rebubbling. There the advantage is, because of the slit view that you can make sure that your cannula or the needle is below the decimus membrane when you are placing the air bubble.
That's correct.
So we can go ahead with the next talk by Dr. Rishi Swarup. We have heard all the speakers talk about the big bubble DALK and the manual DALK, and Rishi is going to tell us what do you do when your patient is not happy and what are the refractive corrections that you can do after DALK. Rishi.
Thank you, Dr. Fogla, and thank you, Dr. Chitra, for involving me in this wonderful webinar. I think the lineup is fabulous and the topics are superb. So the topic given to me was refractive surgery after DALK, and I'll try and cover the what, when, and how of this topic.
Can you be louder, Rishi? Yeah.
Okay, 1 second. Just 1 second. I'll just. I think I'll have to change my settings.
That better?
Yes, yes.
Yeah. So I'll just try and cover the different aspects of refractive surgery after DALK. So when would one think about doing a refractive surgery after doing a deep lamellar keratoplasty? Basically, you're doing this as a procedure to correct a significant residual error, which may be left behind after you have taken out all the sutures, right? You must make sure there are no sutures left and at least 3 months gap after all sutures are out so that the corneal shape has stabilized. And it's only at this stage that you can think of doing a surgical procedure to correct any residual error. If there is a lot of irregular astigmatism, which is precluding a good best spectacle corrected visual acuity, again, that would be an indication to do it. But one must make sure that the wound is completely healed and there's no edema anywhere in the graft or at the graft host junction, because if there is, then your outcome is going to be unpredictable. The surface should be healthy so that you have a good refractive assessment. Otherwise, you may end up doing a wrong correction. Plus, you may have problems with the healing post-operatively. And of course, if you're going to do a corneal refractive surgery, you must have an adequate thickness and appropriate preoperative parameters have to be there. If you're thinking of a phakic IOL, you should have anterior chamber depth, which is adequate to put the lens in. So those parameters, of course, have to be satisfied before you proceed with any surgery. So that's about the when. What? So what will you do when you want to think about a refractive surgery? Of course, the most common refractive surgery is corneal refractive surgery. Traditionally, we like to do LASIK, but I think in post-keratoplasty situations, that's probably not the best option. At least I don't like to do LASIK in my post-DALK eyes. Surface ablation is my procedure of choice, and we'll cover that later. Of course, earlier we were doing a lot of astigmatic keratotomies for high cylinders after DALK and even penetrating keratoplasty. Some people still do that. I prefer to do a laser-based approach. Phakic IOLs are again a fabulous option, especially for those who are not suitable for a corneal procedure. And of course, you can do a refractive lens exchange or even a refractive cataract surgery once you have a cataract in place. So how do you go about selecting the different procedures for different patients? So this is the way I select. If it's a low or a moderate refractive error and there is a component of irregular astigmatism, then I would like to do a surface ablation. And my choice is a topography guided transepithelial PRK with the use of mitomycin C. Some people also like to use wavefront guided procedures. If it is a moderate refractive error and a fairly large graft, so then you could consider going for a LASIK, or a phakic IOL also. And of course, if it's a high cylinder, you could consider a relaxing incision like an astigmatic or acute keratotomy. High refractive error with a good best corrected visual acuity, you can also consider a phakic IOL or a refractive lens exchange. If there is a component of irregularity in your topography, you could regularize the cornea by doing a topography guided PRK earlier and then go for a lens-based procedure. And if you have a cataract or any lens changes, then obviously the choice of procedure is a refractive cataract surgery. Again here, if the cornea is having some irregularity, you can regularize the cornea with the surface ablation and then go ahead and treat the refractive error with a lens-based procedure. So in my practice, essentially, it's these two that I do mostly, and I'll be covering the others briefly, and I'll stick to the ones that I do more. So what are the objectives when you're doing a refractive surgery after a DALK? Of course, any refractive surgery, we think we want to do get an emmetropic error. You may want to do that. Of course, we want to improve the uncorrected and the best spectacle corrected visual acuity and improve the quality of vision. Unlike in a normal refractive surgery, I think in a post keratoplasty scenario, we must not be targeting emmetropia. Of course, we want to reduce the refractive error, but essentially what we want to do is improve the spectacle corrected vision and the quality of vision mainly, so that the patient ultimately is able to see better. And of course, you also want to improve the uncorrected visual acuity, which will happen automatically. So the most common refractive surgery that I do in these eyes is a surface ablation. And the procedure of choice in my hands is the transepithelial PRK, which is topography guided. And of course, in all cases, I use mitomycin C. Basic principle is any case which has had some corneal procedure, you must use mitomycin C, otherwise the chance of haze is higher. Transepithelial ablation, why? Because the epithelium is the best masking agent. It fills up all the irregularities, all the troughs on the corneal surface are made smooth by the epithelium. And if you remove the epithelium and then ablate, you're losing that advantage that the epithelium is giving you. So it's the perfect masking agent, and don't lose it when you're doing any irregular cornea, not just a post-graft eye. A topography guided ablation, because that's where all your irregularity is lying. So if you're trying to do a whole wavefront guided ablation, essentially you're treating the whole wavefront, but most of that wavefront aberration is coming from the cornea itself. So topography guided makes most sense if you have the right platform for it. Surface ablation, again, is much preferred over a LASIK, because when you make a flap through a graft closed junction, you can have flap tears, you can have buttonholes, and these may be flat or steep cornea, so you can end up with free caps, etc. So all those problems can be avoided. Interface problems can be avoided if there's no flap, which are more common in post-graft eyes. Of course, we have to use mitomycin C to prevent haze and maintain the graft clarity. A single-step transepithelial PRK is better than a two-step, because it is a smooth process without a gap between the two, so the cornea will not get dehydrated. Also, the epithelial defect is as small as the ablation zone, so it heals much faster and patient is more comfortable post-op. The procedure should be performed at least 3 months after any sutures are all out. The optic zone size is limited by the graft diameter and the centration of the graft. So if you have a decentered graft, then your optic zone will tend to cross the graft closed junction, so you will have to choose it appropriately. In general, try to take as large an optic zone as you can, especially if the refractive error is lower. The cylinder correction should be, you should try to correct maximum, and even if it comes at the cost of correcting the sphere, it's fine, because that's the one that really debilitates the patients more. And of course, if you have a higher cylinder correction, you want to use more of mitomycin. So anywhere between 30 to 60 seconds, depending on the amount of ablation that you're doing. So this is how you do a transepithelial ablation. When you're ablating the epithelium, you can see the laser dots are blue in color. When you shift to the stroma, they become red. And of course, the ablation is guided by the topography. And then finally, mitomycin C has to be applied. Make sure that the entire ablation zone is well covered. Don't just apply a sponge in the center, especially if you've done cylinder 2 correction. If you don't apply the sides where you have ablated, you'll end up with a haze on the sides. So make sure you're moving the sponge around and cover the entire area of ablation. Post-operative care, the main thing that we have to keep in mind is these are grafted eyes. So you have to step up the steroids and then slowly step them down, just like you would do for a suture removal. And prophylactic antibiotics have to be given for about a week, especially till the bandage contact lens is there. And preservative-free lubricants, of course, have to go on. Some people have suggested this kind of an algorithm to select the kind of stepwise approach to doing a surface ablation in the post-grafted eye. You can look it up when you get a chance later. A few years ago, we just analyzed some of our post-graft refractive surface ablations. These included 2 PKs as well. And I'd just like to highlight that these are a mix of indications, but largely ectasia. And most of these were done at least 20 or 25 months after the initial procedure. And 4 of these 8 eyes needed an enhancement. And in spite of that, the eyes really did very well. You can see the cylinders from as high as 7.5 drop to 0.5 to maximum of 3. And the best corrected vision, almost all of them 6/12 or better. So that is very heartening to see that even in these grafted eyes, in spite of having to do sometimes an enhancement, many of them did really well.
You have 1 minute left.
Yes, so I'll just show you some topographies. This is one of the patients that had a very high astigmatism, and you can see post-operatively got a very good outcome. Similarly, in another case, you can see very high cylinder and vision improved significantly, and the uncorrected vision changed from 660 to 6/9. So of course, other things are there. You can have relaxing incisions. I don't have much experience with these, but people have shown results. Encouraging thing is people have tried to use femtosecond laser to do accurate keratotomies, and this might actually give us a little more predictable outcome. And we'll have to see more studies to see how well this works. LASIK is something I don't really prefer because it has a plethora of complications that can happen. And you probably have better options like phakic IOLs. This is a video from Dr. Fogla. So especially when you have high cylinders, a very high refractive error, this becomes a very good option if you have adequate anterior chamber depth and the iris is healthy. Refractive cataract surgery can also be done, and especially if you have a little bit of a lens change, this may be a good option. Toric IOLs can be used selectively in these cases if the cornea is fairly regular. Some important things to keep in mind is that your wound should be outside the graft host junction. Otherwise, you can end up detaching the interface, and you can end up with tearing the Descemet's membrane that was there, which is a devastating complication for a beautifully done DALC. Okay, so I'll just run through these very quickly. This was just one case. You can see toric IOL got a very good outcome in spite of a high cylinder. Another case post DALC. We did a custom toric IOL from IOCare group. Advantage in this is that you can treat very high cylinders, which is not available in the conventional toric IOLs. And this is just one video I'd like to show in which I'd like to show you introducing the phaco probe. I didn't realize I introduced it in the interface because the clear corneal incision was, the entry was a little forceful. I should have been careful. And you can see I'm trying to take the cortex, nothing's coming. And that should have warned me, but this is the first time I did this. And I just started the phaco and made a hole in the beautifully done bed of the DALC, which is a tragedy for me. But luckily, we managed to treat this patient with a DSEK later. So to conclude, improvement in uncorrected and best corrected vision is the main objective when you're doing refractive surgery in a DALC, and various options like topographic guided transepithelial PRK, or phakic IOLs, and refractive cataract surgery with or without toric IOLs can be used depending on proper case selection with wonderful outcomes. Thank you for your patient hearing.
Thank you very much, Dr. Rishi, for extensively covering it all. I have a question for Dr. Jagdish Reddy. Are you there, Dr. Jagdish?
Yes, Dr. Chitra, I'm there.
So now if a patient develops significant cataract in the post-operative period, how long would you wait to do the cataract surgery? Would you wait till to remove the sutures, or you would go ahead and do the cataract surgery with some sutures still there, because removal of the sutures itself would have a huge astigmatic impact? How would you deal with that moment?
So it depends on what the expectations of the patient are, and also how the topographic astigmatism is. So if the astigmatism is very high, we would definitely consider removing the sutures and then only try to do a cataract surgery so that we get good post-operative outcomes. So other scenario is if you have a dense cataract and patient is visually not able to manage. So this is when you would incline towards doing an early cataract surgery and then manage the astigmatism. So the preference would be trying to minimize the amount of corneal astigmatism and then proceed with cataract surgery.
Thank you very much. I have a question for Dr. Rajesh Fogla itself. Dr. Rajesh, if when you're doing a topo-guided regularization, would you like to do at one sitting, you would do regularization and a refractive correction, or you believe that you should only do regularization and always implant a phakic IOL?
So it depends on what kind of astigmatism and the total higher order aberrations that you have. Sometimes post-suture removal, you find that there can be irregular astigmatism as well, and that is what is affecting the vision. So in that scenario, we first do a topo-guided PRK to normalize the surface. And then if the patient is happy after that with the best corrected vision, we can look at other options, or we can always come back and do another refractive correction depending on the available corneal thickness. So usually a lot of studies have shown that the two-stage treatment seems to give a better refractive outcome rather than trying everything. Because if at the first attempt, if you try to do both, you end up removing a lot of corneal tissues. So a subsequent procedure sometimes may not be possible because of inadequate corneal thickness.
Yeah, in fact, the enhancements in my case were those only. I initially regularized the cornea and then gone back and treated most of the refractive error later.
Haze is not much of a challenge, no?
No, not in my
If
case.
you use mitomycin C and if you give topical steroids at least for 4 months, I think haze is not much of an issue.
And because these are grafted eyes, we tend to put the steroids a little longer. So we usually don't see haze in post-graft eyes at least.
The only problem is once the patients achieve good vision, they often tend to become non-compliant on the steroid drop. They may keep telling you that they are applying, but they become irregular and that can result in haze. So I think it's important that you do a follow-up visit at 3 months so that even if you can pick up that early haze, you can always step up the steroids rather than the patient coming back at 6 to 8 months when the haze is much more dense.
I think
We
all
have
these post-DALK and post-keratoplasty patients, I'm very fond of contact lenses for these patient or rehabilitation, because most patients would be assessed on a contact lens. So if you look into keratoconus patients, and they adapt to a contact lenses post-surgery very well also. And with the newer designs of contact lenses, their outcomes are very good. And I think that would be another option for these patients to have a good visual recovery in these cases. So I practice contact lenses more often, rarely think of doing a laser treatment for these patients, because sometimes to predict the outcome is also very difficult, and you can create another surface problem for these patients. As is, most patients will have a poor surface after surgeries, especially the chronic ocular surface problems, which will be there in some other patients. The contact lens should be a good option and should be kept in a armamentarium for these patients.
Thank you, Dr. Tithia. We shall now go on to our next speaker, Dr. Shreyas Ramamurthy, the consultant cataract, cornea, and refractive surgeries at Eye Foundation Group of Hospital, a brilliant surgeon with amazing skill sets and contributions to publications. He is going to be talking to us on DSEC in challenging situations. On to you, Shreyas.
Thank you so much. Good evening, everyone. And today I'll be talking about DSEC in challenging situations. Just give me a second. So with the advent of DMEC and the popularization of DMEC as a procedure and standardization of DMEC procedures, DSEC is slowly getting relegated to these challenging situations. And we still see a fair bit of such challenging situations in India, in our country. And essentially, to have a successful DSEC procedure, the main prerequisite is to have a sufficient and possibly a fairly tight airfill for initial duration of time. And this is challenging to achieve mainly in patients who have aphakia, where the iris is not regular or is damaged, patients with failed grafts, again, patients in vitrectomized eyes, or post-trab and tubes, where maintaining the air bubble can be quite challenging. So I'll take you all through a series of videos with just one example for each situation and try to highlight what could be done to overcome these challenges. So in aphakia, if the pupil is round, you could go ahead with directly with DSEC in an aphakic patient, especially if the other eye is also aphakia. But more often than not, in this time and age, we don't really see patients with bilateral aphakia. And it is usually a complicated cataract surgery which has resulted in aphakia. So the choices that we have are an anterior chamber IOL or a retro-iris fixation IOL or a scleral fixated IOL. And there are sufficient literature to suggest the advantages of each. So let me take you through different examples where I would use these different sets of IOLs in different situations. So this was a patient with a very edematous cornea and a subluxated PMMA rigid IOL. And this was a large 6.5 millimeter haptic IOL, and this was dislocated and this had to be removed. Very important in all these cases to do an adequate vitrectomy. Now, when the anterior chamber is deep, there is no peripheral anterior synechiae, anterior chamber IOLs can actually still be a very, very good option. With these deep anterior chambers, studies have also shown, even one published from SNEC, that outcomes of DSEC combined with anterior chamber IOLs can be comparable to that of a scleral fixated IOL. A well fixated anterior chamber IOL, which is stable, of the appropriate size, can actually give you a very good outcome. And more importantly, in this patient, as you can see, there is a large iris defect. Almost half the iris is missing. So this anterior chamber IOL also gives a scaffold for holding the air bubble in place in the anterior chamber, and therefore making the procedure a lot easier. A different situation where there is again an edematous, extremely edematous cornea in a patient who has undergone a complicated cataract surgery. Now, first again, anterior vitrectomy is extremely important, making sure that no vitreous strands are there in AC, which can really compromise your outcome for your surgery. Now, in these hazy corneas, using an iris clip IOL is not only is it easy, it's quick. And my initial concerns when I was using this, my initial cases, was whether during the air tamponade procedures, this iris clip IOL would remain stable or whether it could get disinclavated, which could be a nightmare in this situation. But to my pleasant surprise, I've done quite a few of these cases. The iris clip IOL is extremely stable, whether you're doing a DSEC or even an open sky procedure like a PK. And it's a fairly quick and easy procedure, and you can easily go ahead and combining it with a DSEC procedure, even when you need a tight airfill. Now, this is a more difficult situation, which is a completely vitrectomized eye. There is a significant amount of peripheral anterior synechiae. It's a one-eyed patient and with a opacity in the inferior cornea. Now, because it's a one-eyed patient, I want to attempt an endothelial keratoplasty, not go in for a PK. But in these vitrectomized eyes, you must remember that the eye can be extremely soft. And as you can see there, the eye started collapsing as soon as I made the incision. So we use a pars plana, irrigation device, or at least an anterior chamber maintainer, and then go ahead and using a stable globe, you can go ahead and complete the SFIOL procedure and then go ahead with your DSEC. But the challenge here is maintaining a stable air bubble in the AC. So you will have the air bubble diffusing away into the posterior segment, but alternating the right fluid dynamics, inserting some saline in between your air bubble is extremely important, because in these eyes you could actually see that the air bubble goes behind and tends to tent up the iris forward, which can be a little more difficult in maneuvering your graft in the anterior chamber. So alternating saline and air bubble is important. While even at the end of the surgery, well, you can see there's a large air bubble in the anterior chamber, but the posterior chamber is also filled with air. That's when you actually end up having a tight fill. And needless to say, all ports have to be sutured, including the pars plana ones. If you're trying to leave the patient aphakic, something which can be used is a hitch suture if you are not able to get a tight fill. And this hitch suture can hold the graft temporarily till the endothelial cells start pumping and the interface fluid is gone. Again, as I mentioned, managing the air in the anterior chamber is extremely important in these eyes, and ensuring that it doesn't all go into the posterior segment and pushing the iris forward. The other very difficult situation is in failed grafts, which are edematous, especially post-therapeutic grafts, where you can have an altered anterior segment architecture. There is a significant amount of peripheral anterior synechiae. Some of these therapeutic grafts are large. They have altered corneal contour. They could be a little eccentric. Some of these patients could also have a retrocorneal membrane because of the increased inflammation in the early postoperative period following the initial graft. And they also have concomitant cataract and glaucoma, which is very common in these failed grafts as well. So when you're, some of the common principles that we need to follow while you're doing a DSEC in a failed graft is, while you're making your incision, make sure that the incision does not traverse the graft-host junction. That's quite important. And you want to try it making it a little posterior. You can either use a limbal or a scleral incision. DM stripping can be a challenge in these eyes. Especially you don't want to compromise the integrity of the graft-host junction. So unless you have a dense retrocorneal membrane, you could do an ASOCT and then figure out if there is a higher posterior reflectivity. If there is, then go ahead and do the stripping. If not, you could actually do the DSEC procedure without stripping the DM as well in these cases. Sizing is extremely important. You want to leave it a little smaller than your original graft size so that it is not overlapping the graft host junction. Peripheral anterior synechiae also need to be released to some extent, although if it is not very extensive and is focal and at one point, I don't mind leaving it in place and going ahead with the DSEC procedure. I always do an inferior PI in all these cases. You want to fill it with an anterior, an air bubble before to kind of assess where the synechiae are and how much of it has been released and to what extent the air bubble is spreading to the periphery before you go ahead with the procedure. I don't commonly do venting incisions, but they can be useful in some of these eyes where you don't get a tight airfill and you could release some of the interface fluid once you have a reasonable fill with the air in the anterior chamber. These venting incisions help in reducing the fluid in the interface and thereby helping faster apposition of the DSEC lenticule. So I'll try to put it all together in this particular video. Now, this was a patient with a very hazy cornea following a large therapeutic graft which has failed and a significant cataract as well. So the main challenge here is to improve your visibility. While you don't want to really remove the epithelium very quickly in these eyes which have a large graft where LSCD could be present. So using a chandelier illumination is very, very useful. I also try to use topical or rather glycerol spoked sponge to remove the, to cause a temporary stromal detergescence, which could be quite useful. And then you can go ahead with your improved visibility and with the chandelier illumination, you can go ahead with the phaco. The phaco is definitely far easier once you have better visibility. You can do a safe in the bag phaco. It's extremely important that you have a good phacoemulsification done before your endothelial keratoplasty, and as far as possible, place the IOL in the bag, which helps in preventing any the IOL moving forward during your air bubble maneuvers. In this case, because it's a large graft, I've made the incision within the graft itself, which helps in kind of tamponading the incision using, as you can see here, despite it being such a large lenticule, large graft, it seals quite well because I've made the incision a little more anterior and the DSEC lenticule itself is sealing the graft. And again, a few venting incisions are made because it can be quite challenging to get a tight fill in such cases. So despite these difficult situations, using a planned approach, using the appropriate IOL for that situation, which acts as a scaffold for your air bubble, and using techniques to improve your visibility, sizing the graft appropriately, especially in failed grafts where you don't want the graft to be exceeding the graft host junction, where especially if the graft host junction, posterior graft host junction, if it is not very smooth, this can lead to a irregular overlap, and that could lead to a small gap in through which the interface fluid can actually come in and cause the lenticule to detach. So with these techniques, we can have good results even in these difficult situations. Thank you so much for your kind attention.
Thank you, Shreyas, for those wonderful collection of videos which you showed. Just one question: how would you manage a DSEC if there's significant PS and associated glaucoma? Which would you treat first?
Well, if the the fundus is visible, or if we are able to accurately measure the IOP, which actually can be challenging in these situations, so the diagnosis of glaucoma itself becomes a little difficult. But if we are able to measure IOP or visualize the disc, and we do see significant glaucoma, then possibly addressing the glaucoma first using a trab or a tube procedure would be ideal. And once the IOP is under control, then we can go ahead with endothelial keratoplasty. Any keratoplasty procedure for that matter, when the glaucoma has not been addressed, can be quite a disaster. So definitely address IOP before. I'm sorry, I missed that point in my talk.
Dr. Rajesh, should we take questions or shall we go on to your talk? I think we have three more speakers.
We have 3 more speakers. We can go ahead.
So we look forward to our very eminent moderator and speaker, Dr. Rajesh, who's going to tell us give us tips for graft preparation. And I would want Dr. Bhaskar Srinivasan to come up with questions for him. On to you, Dr. Rajesh.
Yeah, my slides are visible.
You started? Yes, yes.
At the outset, I would like to thank Dr. Chitra for involving me with this ARC session. My topic is donor preparation in DMEC. I have no financial interests. Now, Decimus membrane endothelial keratoplasty is the preferred technique of replacement of the dysfunctional endothelium. Here, the donor Decimus membrane is harvested and injected into the host anterior chamber, where it is unfolded using a no-touch surface tapping technique. And once the stained Decimus membrane scroll is unfolded, you use a air or a gas bubble to secure it in place. And this has given faster visual recovery with a greater percentage of patients achieving 20/20 or better, and it has the least risk of endothelial rejection. Now, this is a paper published back in 2019 where they did a survey among people who had completed a formal training for DMEC. When they went back a year later, majority of them were still not doing DMEC, and in the survey they indicated that almost 50% of them indicated that it's the anxiety related to tissue preparation because of which they have not been able to start with the DMEC surgery. If you have a DMEC preparation failure, you have a loss of donor tissue, which can lead to cancellation of surgery. You have to get another tissue from the eye bank, so you have to, again, additional cost. And this makes the learning curve for DMEC steeper. And depending on the experience of the surgeon, the loss rates may vary between 2 to 20%. In the Western country, especially in US and Europe, you have the eye banks doing this job for you. They may give you either a pre-strip donor where the Decimus has been peeled off 80% from the stroma, and then all the surgeon has to do is to punch out the desired size and complete the peeling. Or they go a step further, they even prepare the ideal size DMEC scroll, stamp it, stain it, load it into an injector. So it's called the patient-ready DMEC donor. But all this comes with an additional cost. The average cost of a pre-stripped DMEC donor or a patient-ready DMEC donor varies between $2,500 to $3,000. Here in our part of the world, the donor tissue has to be prepared by the DMEC surgeon. You can do it pre-operatively 24 to 48 hours earlier, or you can do it even during the surgery. The ideal donor age recommended for somebody starting out with DMEC is between 60 to 75 years. The cell counts 2,500 or more. You definitely would like to put a S or an F stamp on the stromal side to help recognize the orientation. And the trypan blue staining is done for 1 to 2 minutes duration. And this paper published in 2013 found that you can, in 98% of the eyes, you can fairly prepare the DMEC graft in a reproducible manner. And the younger age group, the tissue tends to scroll more, it is more elastic. And if you go older than 75 years, the scrolling is less and the tissue also becomes a little bit more brittle. The donor preparation, this was the earliest reference from Frank Price and Arthur Giebel, where they described the scuba technique or the submerged cornea using background survey. So they would do a peripheral break in the Decimus using a blunt-tipped instrument, following which the tissue is immersed in the donor storage solution. So the surface tension is minimized, which allows easy handling of the Decimus membrane as it's being peeled off. And also, as it is floating in the fluid, the reflections from the background go away, allowing better visibility. And once you have done the partial peel, you would prepare the graft as what we'll show subsequently. The other major advancements was from Peter Wellman from Mark Terry's group, where they showed that you can use a 2mm or 3mm punch to create a stromal window and then access the Decimus membrane from the stromal side to put in a S stamp, which again helps in identifying the correct orientation intraoperatively. So you do a partial trephination, 9.5 to 10 millimeter. Then you do an edge lift, after which you do a partial peel of the Decimus membrane, about 50 to 60%, and then keep it folded. Go ahead, do a stromal punch using a dermal punch measuring 2 to 3 millimeter in diameter. Then you can float the Decimets back into position. Now flip over the donor tissue, access it from the epithelial side, open up the stromal window, put in your S-stamp, and then you can come back and you can put in your 8 millimeter punch or 8.5, whatever you want, and then you can peel off the donor and then stain it with trypan glue for your surgery. This we published back in 2015. Now here, looking at the two different techniques, the peripheral break can be done using a Trifine, which is a 10 millimeter, 100 micron depth blade, or you can use any pointed instrument to create this peripheral scraping, whereby you only break the Decimus membrane and you don't break the stroma. The disadvantage is that if you create that peripheral punch a little deeper, then in younger donors, especially, you're getting that peripheral edge to become free or to identify the Decimus membrane at the periphery can be very challenging. So that's advantageous when you just do a peripheral scrape. The disadvantage of the peripheral scrape is that it can create irregular edges, for which you have to go and remove those peripheral tags. Otherwise, they would lead to formation of radial tears. So you do a partial peel, about 60 to 70%. It's important when you are doing this peeling process that the entire Decimets which is separating separates in a straight line and you don't see any stress lines, because those are areas of abnormal adhesions where you can get a horseshoe tear. Or if the periphery is not free, you can have creation of radial tears which can extend centrally. So once you have done that, you make the stromal punch, float the Decimets back into position, flip over the donor tissue, and you can see here that we are drying the edges and then flipping over, making the F stamp, and then you can do your desired 8 millimeter. 8 millimeter is the common diameter that we use for most of our surgeries. And then you can complete the peeling, what you see here. That's almost 80%, which is already partially peeled, and then you complete the peeling process and you can stain it and use it for your surgery. So that's what I was trying to indicate, that if you use a peripheral punch, you get a nice circular cut. But if your depth of the cut is little more, sometimes identifying the free edge of the Decimus is difficult. When you do a peripheral scrape, you break only the Decimus. There is no break in the stroma, but you can have irregular edges. So you have to first go ahead, remove those tags so that you don't get a radial tear when you're doing the peeling of the Decimets. This is a nice paper from Mark Gorovoy, where they looked at the donor tissue characteristics. On an average, the peel time was about 10 to 11 minutes, and they found that only in about 6% cases they got the tears, out of which 3 they could, almost 50% of them, they could manage to use for surgery despite having the peripheral tear or non-central buttonholes. So almost 97% of the tissues were used. They found that tissues which were older than 65 years had slightly faster peel time. And if you did have a complication in one donor eye, the pair would also have the same problems while peeling. So it's important that if you have received a pair of donor tissues from the eye bank and you have complications in one, don't go ahead and try to peel the Decimets in the second one, because you're likely to have the same problem. So what I do is, if I have a problem with the peeling of donor on one eye in my surgery, I definitely inform the eye bank about that, so that if they have given the pair of the tissue to somebody else, they can indicate that this was a problem that happened with the first donor. The other problem is that when you are doing this regular peel against a white background, the edge is not seen very clearly. Then that can result in delayed identification of the tears. So this is something that we devised 2 years back. This is an illuminated chamber, which is a battery operated illuminated base onto which a transparent endothelial punch block is placed. And here you see that it provides a retroillumination. So now here, when you peel the Decimets, just like you see your capsular axis, here you can see the Decimets pretty well. And this way, if you do encounter any radial tear or a central horseshoe tear, that can be picked up much easily. And it makes it easier for you to, overcome the learning curve for preparing the donor tissue as well. So you can see the difference in the contrast of the edge that is getting peeled off standard versus using the retroillumination device. There are other techniques of injecting fluid or a liquid bubble technique, where you inject trypan glue dye in the peripheral stroma to create a type 2 bubble. Not very reproducible in my hands. You can do a pneumodissection, which I think Susan is going to talk about. You can do manual dissection of the Decimus membrane using dissectors, which Donald Tan likes to do with his micro dissector. And Dr. Mouraine from France has also described where he mounts the donor tissue with the endothelial surface facing up on an artificial chamber. And then he tries to dissect the Decimus membrane using a hydrodissection cannula. Recently, Zamali sponge has been described from Italy, where it's like a yogurt peel technique. This again, it works, but not necessarily in all kind of donor corneas. So this is in short about the donor preparation in DMEC, and thank you for a patient hearing.
That was a wonderful presentation, Dr. Rajesh. Dr. Bhaskar Srinivasan, on to you. One question, we'll have to go on to the next speaker after that.
A lovely talk, Dr. Rajesh. Just wanted to know, in case you end up having a tear of the donor while preparing, how would you go about using the same tissue, or you use a spare tissue?
So we have used donor tissue even with 30 to 40% of the tissue being lost. So you can still go ahead and use it like a hemidemic. The only problem is that there will be, if you have already stripped the Decimus membrane from the host, the bare area of the stroma, there will be some persistent edema which you have to manage. Over a period of time, that edema will resolve. You will have a slightly lower cell counts, but it is something that can be managed. So you don't really need to discard the donor tissue, even if you have peripheral tears. The only thing is early recognition. Sometimes if you feel from the periphery that the dissection is not happening as you plan, you can either, instead of proceeding with that, if you have another tissue, you can move on to using another donor tissue, or you can convert it to a DSEC. So you can mount the tissue on an artificial chamber, then prepare like a DSEC graft, and you can use the same tissue for a DSEC without creating more problems.
Thank you very much, Dr. Rajesh. So we shall now go on to our next speaker, Dr. Siddharth, who's a senior consultant in cornea, cataract and refractive surgery from the Shankara Group of Eye Hospitals, another extremely skilled surgeon with a brilliant career ahead. He's going to be talking to us on surgical pearls for graft failure. And Dr. J.K. Reddy, I would want you to take a question for him. On to you, Dr. Siddharth.
Yeah. Thank you, Dr. Chitra and the ARC team for inviting me for this PG update. My topic is a very different topic here, because I have talked and I've heard a lot about graft preparation and the unfolding techniques, but this portion of graft delivery is a very small portion, meaning that after you prepare the graft and until you try to unfold. So I would like to discuss with these three components, my talk is going to be around this. So as Dr. Rajesh Fogla very clearly showed different techniques how to remove. The most important part is, like as he showed, there may be peripheral tags, there may be irregular removal in the periphery, and then when you punch, it can readily come inside the center and tear the entire tissue, or it can have a wrinkling into the center of the DM. The second part is how you transfer into the injector, and the third is how do you deliver it into the eye. So for example, I want to show here, there are actually, I've finished the DM removal, but I see there are two small tags. Being overconfident, I really overlook it. And as you see that I'm trying to remove it perpendicularly, you see that the tag extending it. This is actually a very small tag. If I could have removed there, this tissue wouldn't have torn into the center. So you could prepare a very beautiful tissue, but when you punch, you have to be very careful, or you will end up with these type of tags at the end. The second part of my talk is actually how do you transfer it into the injector. A very lot of type of injectors is the initial ICL cartridge, and this what prototype I use. Whatever injector you use, you have to have certain technique to take it inside the injector. And the third one is delivering it into the anterior chamber. If you do it very fast, it can get caught into the tunnel, or if you do very fast, slow, you will be ending up finishing all your saline in your injector, and you are caught up in this portion. So I'll be talking how to rectify each and every step. Before that, I don't want to go into a debate here. Just want to make 2 points here, because I have no financial interest in any of these injectors. You want a plastic, you're a glass, there's a huge debate. You decide what you want to do, whichever is comfortable, you can do it. And also the size of the injector, whether it's a small, large, whether you want to keep the exact 2 scroll, double scroll, whatever you want to keep. You want to plan to inject right into the correct position. So 50% of times you can get a right one, 50% you don't get. Nobody is an expert in exactly putting it in, but you have to make your way in however you proceed doing DMAC as you become experienced. There are a lot of injectors. You can choose whichever is comfortable for you. The only thing is there are two techniques. I think 90-95% of surgeons, they use a direct method, and pull through is another, just for postgraduates to know that there is a pull in through also like a DSAC, but most of us use only a direct method. So a few things what I've learned over the years is 3 steps I will explain to you. So after doing a very good tissue removal, the periphery of the DM is usually removed. And as you remove the DM, you have to keep a look at the periphery. There are no tags or any irregular cut. It comes out very well, no problem. And I usually stain it at that position. What happens in some cases is that your trephine may not be good, your trephine edge may not cut properly, or you wouldn't have removed completely. So you look here, as I remove, there is a tag or there is maybe an irregular cut. So here what I do is I hold the tissue, and just like a rexis, you have to do it. You should not pull perpendicularly or tangentially up, you will end up tearing it. So here again, I've done a punch. The unstained portion is, I have not removed the 100% of the DM, because usually we remove only 90%, but sometimes it can come into your punch portion. So the other side also I'm trying to remove, it is not coming. So I have a very big area of unstained portion. Take time, put some stain, see how much you're stained. Now you're very clearly able to see that this portion is not very clearly removed. So go again there, do a, as I told you, a circular like a rexis portion, it usually beautifully comes. So here it's a very minor thing, but if you can concentrate on this, you will not lose the tissue at that juncture. The second part which I was telling is like, this is the portion where you will lose your maximum amount of endothelial cells while you transfer, because we have showed very good videos where very beautifully you can take into the injury, but this happens even a very well trained DMAC surgeon. We can find it sometimes difficult to get it inside. So injector, what I've been, me and Dr. JK, we have been using it for more than 400 to 500 cases. So an ordinary 1cc syringe with a IV set, and there's any normal C cartridge what we prepare every time, and we use it. And this is a BSS. We put it into a normal IOL tub and then fill the injector with BSS. And then what we do is we remove the DM, and we put it into this injector so that we have a space to move around. And most of the times it scrolls in very well. You can beautifully take it in. Sometimes elderly tissue, when you start in, may not scroll in, may look large. But what I want to show you here is, see that the endothelium is outside. I put an L mark. So our aim is to inject it just like that inside, so that we can unfold it. This L, you want it in the same position. So here I'm trying to rotate it, see that the L is in the right position, so that when I inject it in, I will unfold it the same way. So here you can see that the tissue is reversed, meaning that you see that the L is reversed. So I'm trying to suck it. It's actually a broader portion. Actually, we should suck it towards a narrower portion. I'm trying to suck the broader portion. It's not coming in. Again, I'm trying to take it in through the narrower portion, but this side becomes broader. You see, I flip it. Once I flip it, I'm able to see that my mark is okay, and this is how I want to inject, and it comes in very well. And here again, I repeat, this is what I do. I just see the mark, it's okay. So this is how I want it once I inject it into the eye. So I try to take it into the injector. And again, reinforcing a broader area. Don't go, you rotate it, take the thinner, the area which is narrower. And as you suck, you have to give maximum force for it to come in. And once it comes in, you have to slow down your suction, and slowly it comes in. So here, the other one which sometimes when you stain it and when you use your non-toothbrush, it can get caught. Just leave it into the saline for some time. It usually gets released. Here, what happens is, what I learned is, I try to suck it as it is like this, so that I thought it will be narrow, but we should never do it, because if it is stuck like this outside, once it goes inside the eye, it is difficult to suck it in. So actually, if there is any portion stuck, release it however way you want it. See that my L portion is, L is okay. So now I take it in. So here, what you have to understand is that you can take it in whichever position, but this is how I usually see that the L, I wanted to go inside smoothly and so that I'm able to open it. So this happens 50% of times, 50% you cannot go in because once you inject it, it can get scrawled, it can get in a different way, it can go in, but this is how I try to do it. So the third is delivering into the DM. Everybody wants it to be very beautiful, going in very smoothly and unfolding, and but it doesn't happen always. What happens here is sometimes, as I showed you first, it can get caught into the tunnel. So at this stage, we really don't know what to do because the saline is over in your syringe, or you don't know what to do. You have to take it out, and then you have to push it in, and all these causes a lot of endothelial damage. So this is another thing which I show you a tight tunnel, and I'll be injecting fast. So you see that inject fast and tight tunnel, you'll have the DM coming out and the cells can get damaged. So what I would suggest is, see, I'm going inside and injecting it. So it goes into the antechamber. Again, I'm stuck up into this half portion. Since we are all phaco surgeons, we are ambidextrous. Take your left, with your left hand, take the saline, and as you inject, you see that the tissue goes in your side port, and then you take out and see what is the problem. And most of the times the speculum, you have to adjust the speculum because the speculum is the main culprit, may be very tight. So you have to loosen it, form the anterior chamber, and then you see that it beautifully goes. So such a small correction, that because you have to make the anterior chamber soft when you inject. The second is your tunnel. Don't fight over your tunnel. If your tunnel is small, please make it a little bit large. Do not fight over the tunnel because you will have problem when you inject. I fear I'm doing that, and again I'm releasing the speculum. Make the eye as much soft as possible so that you don't get any backflush fluid into your syringe. So once you enlarge, it goes in very beautifully. Here again another eye syndrome where there is no space. As I go in, I see that the iris gets plugged in. Pardon?
You have to conclude.
Yeah, I'm going to conclude. Yeah. So once it goes in, you can put the saline in and you can inject it into the. To summarize what I have talked, take the DM very carefully. If there are any tags, remove it in a circular portion. So this is a very key point. The second point, what I want to tell is when you take it, I usually take it in the normal L shape which I want it to unfold. And third, make a very smooth injection, and you can see that the L mark is there. And then always suture it, make a suture before you try to manipulate. You see that one suture is very, very mandatory before you do it. And then just little bit tapping saline, and that's it. Actually, it's an unedited picture, and then that's it. So, okay, thank you. And choose what is comfortable, repeatable, and successful in your hands. Thank you.
One quick
Thank
question,
you
Dr.
very much,
Siddharth.
Dr. Siddharth. Yeah.
How you
Yes.
manage in the case of aphakia or
Can you stop?
large PI with vitrectomized eyes? When you inject, the eye is so soft, the graft goes into the vitreous. Has it happened anytime to you, or how do you manage?
It happens most of the times. Aphakic cases, I try to do an iris claw. Other than that, if it is going to be aphakic, most of the times iris claw is the only solution. But if, as you say, if there is a very large PI, then I would like to do a DSEC in all these cases, and rather than to do a DMAC, because once it goes inside the vitreous, it becomes difficult, and also post-operatively, air management becomes a difficult portion. So most of the times when there's a large PI or it's aphakic, you're not able to do an iris claw, most probably go for a DSEC. I would prefer a DSEC.
What you do goes into the vitreous. You leave it, or you ask the vitreous surgeon to take it out like a IOL.
So I had one case previously, then we had to take it out and discard it, and I was not able to remove it. I don't like to fish it. Maybe I'll ask the surgeon to remove it out and then put a fresh piece, or you have to leave it just like that. You cannot too much manipulate once it goes into the vitreous.
Thank you. Very good questions. We shall now go on to a last but a very dynamic surgeon and speaker, Dr. Susan Jacob, who's the director of Dr. Agarwal's Refractive and Cornea Foundation since 21 years, specialized in refractive surgery and also cosmetic oculoplasty, and is one of the top 100 women ophthalmologists to be reckoned world over. A genius with her innovations, par excellence, and has contributed to major textbooks in ophthalmology, a huge trail of publications and awards to her attribute. So she is going to be talking to us on a favorite topic, PDEC, the learning curve. On to you, Dr. Susan.
Thank you so much, Chitra ma'am, and especially for inviting me here and for giving me that lovely introduction. I always love it because your sessions are always so dynamic and so full of knowledge, and the way you bring out the questions from different people is amazing. So thanks for having me here. I'm going to just share my screen now, and just please let me know if you can see it.
Yeah, we can.
Thank you. So my talk is on PDEC, and I'm just going to go through some very basics. I think this almost all of us know that PDEC basically is also includes the pre-Descemet's layer or the Duas layer, which gives it the ability to, which gives us the ability rather to create these graphs from very, very young donor tissues. So you can get extremely young donor tissues, and therefore you can get a much larger endothelial cell reserve to start off with. And also the very classical difference that can be seen between the PDEC and the DMEC bubble. Dr. Fogla showed these beautiful DMEC graphs being prepared and how to do these. And as he said, you can also do it with the bubble or the saline, the fluid injection. And how we prepare the PDEC graft is just basically by either air injection or maybe with the storage medium or just with some BSS. And you can see here, this is the classic PDEC graft and this is a classic DMEC graft. And you can see the DMEC graft looks much more flimsy, but it is larger and it's got these sloping edges. Whereas the PDEC graft starts out from the center, expands to the periphery. It's very much like a DALC bubble seen on the reverse, and that's exactly what it is. And you can see that it's smaller in size, but this is basically midway, and you can generally get larger PDEC grafts, as I'll show you later in the video. And these basically are tougher, stronger graphs. And that's one of the big advantages. So if you look at the PDEC graphs, what are the advantages? One is you get a larger quantum of cell transfer. You get lesser effect of surgical loss because the surgery really becomes easier, and I'll show you that later. You get good corneal clarity because you're using such young donor tissues, decreased chance of primary graft failure, and longer graft survival. So that was a 1-year-old graft. And the other big advantage is that of resilience, which is that it's a very tough, robust graft and does not tear. And so there's a lot of ease in tissue handling. And so that is a PDEC layer. Basically, you can see that it doesn't tear at all. And you would never be able to do with that with the DMEC graft. And that's something that's very flimsy. And any small tear or rip in the periphery can just extend along a DMEC graft. Now, this is basically my philosophy for doing the PDEC surgery. Keep it simple and sweet. So what are the basic steps that I use to overcome problems? And that gives me the ability to basically combine advantages of both DZEC and DMEC, that is easy graft handleability as well as wonderful results. E-PDEC, air pump assisted PDEC, host decimetric scaffolding. These are some of the techniques that I've described, and also the importance of an iris IOL diaphragm. So let's look at the E-PDEC or the E-DMEC technique, which we had published in the Journal of Cataract and Refractive Surgery. It's very, very simple. Basically, it makes all the difference because you know that when you're looking through the microscope light, your view is not good because you're looking at it perpendicular and straight down. And the minute you go on to oblique light, which is shown from the periphery, you can see all those folds and all those reflections that come off the graft, and this can of course be used for DMEC as well. And so you don't really need to use any other devices. You don't have to use expensive OCT devices, which of course most people would not have. You don't have to use the S stamp or the L stamp. I've never used it, in fact. All I do is the E-PDEC technique, and that gives me this beautiful visibility just because you're seeing it with oblique light. And as Shreyas also showed, you can also use an endo illuminator, which is fixed like a chandelier illumination. And that's another way of doing using an endo illuminator. So here's again just another graph that's seen with the endo illuminator, and you can see the difference, the stark difference that just the use of an endo illuminator makes to your surgery. The other technique is the air pump assisted technique, and that's also something that we published both in Cornea and clinical ophthalmology. And here is what we do. This is a failed graft, as you can see. And what I've done is I've injected the graft in, and you can see that I'm really unlike DMEC, I'm not really so much bothered about how well centered it is, whether I've got these edge folds. These don't matter to me, and therefore my surgery is really fast. It goes really fast because I just go ahead and inject it in, and I can just draw it into place. And that's the beauty of the PDEC graft, because it gives you the ability to do this. A DMEC wouldn't allow you to do this. And the air pump is continuously infusing air, acting as a third hand, and that helps me hold this graft in place and bring it into position nicely, open up those edge folds, and then close it with air. And that's the 1 month postoperative appearance of the same patient. And you can see you get beautiful results with the air pump assisted PDEC. In fact, your rate of graft detachment goes down hugely because you've already got the graft attached even by the end of surgery. So our graft detachment rate is extremely low. It's almost close to 0%, I would say. I've probably done one rebubbling, but otherwise it's extremely low. And I really attribute it to this technique, the air pump assisted technique, as well as another technique, which I'll show you also, which I call as a host decimetic scaffolding. Here's another example of the air pump assisted technique. You can see that the air is going in, acting as a third hand, holding it in place, and you use this reverse Sinski, and you can easily open up those edge folds and take away all that DMEC dance. So the DMEC dance is also something that does cause endothelial loss because you're rubbing it over and over against the iris and all that. And here you can have this young tissue which does fold up more, but still you can get it to be largely unrolled and just take, except only those peripheral edge folds, and those you can easily unroll with just the air pump assisted technique. So here's some difficult cases which show you how you can do this technique even for difficult cases. The PDEC technique using these assisted techniques like the E-PDEC, the air pump assisted PDEC. You can see that's a valve, and I've put the graft in. I've opened up the graft. And so that was obviously a valve that was put in the anterior chamber causing corneal decompensation, and I repositioned it into the posterior chamber. So that's the postoperative appearance of the patient. This is the host decimetic technique, the host decimetic scaffolding technique. And this technique actually is a beautiful technique because it allows the graft to be held up and prevents its detachment. You can see that the decimetorexis that I'm doing is actually a little smaller in size. And the reason is that once you put the graft in, that's again the E-PDEC technique, showing you the orientation of the graft with the scrolls facing upwards, which shows you beautifully that it's right. I've opened up the graft to whatever I feel is a good enough amount, and you can see there are those peripheral small edge folds on two ends. I'm not bothered about them. I got to get in my air pump assisted PDEC in, and with the air infusion flowing, I reposition that graft, center it to whatever is appropriate. And now if you look at that technique, that's the host decimetic scaffolding, where I kind of tease out that host decimetes which was lying above the graft, and I bring it out now to lie below the graft. So what this host decimetes does is it holds the graft in position, acts as a scaffold, and prevents its detachment in the postoperative period. You don't necessarily need to do it all around. You could just do a little bit of host decimetic scaffolding on either side, and that will also work in the postoperative period to prevent detachments. And here's the postoperative appearance of the patient. Here's also another case using the same technique, just to show you that you don't have to do it all around, but you can also just do it in a few areas. And you can do this using these techniques. As I said, you can do all other kinds of complex cases as well. This is a glued IOL, and I'll rush through this because just for the sake of time, I've got the glued IOL in, vitrectomized eye. So you can see the PDEC graft is in, and we unfold it, put in the air pump. The air pump assisted technique is going on. As you can see, the graft is put in and the graft is unrolled. And that's 1 week post-op with a 6/6 appearance. Here's PDEC with aniridia IOL. So this is again a situation where there's the large areas where the graft can potentially go down, sink into the vitreous. But again, this technique, and the ability of this graft to be managed easily within the anterior chamber gives me the confidence that I'll be able to do this without any problems. And what I do here is I just center that aniridia IOL a bit because it was seeming to be a bit decentered. Once I've done that, the rest of the technique is the same. I've got the graft in, the air pump prevents it from dropping into the vitreous, and then we open it up and center it, and basically that's the end of the case. And that's a postoperative appearance. Again, retrocorneal membranes, you can see that's a retrocorneal membrane with the iris also stuck completely to the back of the cornea. As I went in with the air pump, it actually separates out. The decimetes just gets detached along with the iris which was stuck. And you'll see now the appearance. That's the entire retrocorneal membrane which has gone back, and it's also adherent to the iris. So what we do now is we go ahead and dissect it with scissors, strip it off the iris as well, get all those iris membranes off, and do a fourth-row pupilloplasty, basically get the pupil into shape, put in the graft. And you can see this cornea doesn't really look great right at present, but once the PDEC is in, the graft is in, open it up, do your air pump assisted techniques, and you can see post-operatively you get really a beautiful, dramatically clear cornea. Here's another example, again with iris membranes, and this cornea, this is a failed graft, as you can see. So this is a very complex case, a failed graft with a very bad looking appearance of the cornea, and you probably prefer to do a repeat penetrating keratoplasty in this. But you go ahead and what I'm doing here is a needle dissection of that fibrous membrane which is over the iris. So you gently separate it using a needle, and you can dissect it completely off the iris in that way. Take out the membrane. So now you've got a much clearer view. And then you go ahead and fix the rest of the anterior chamber, do a glued intraocular lens. So this you can see is multiple things: vitrectomized eye, failed graft, glued intraocular lens, pupilloplasty, and all those things. And finally, we get the PDEC graft in there. You can see it's stained with trypan blue. Use the pump pesticide technique, open up that last fold, and that's the first day appearance of the patient. And you can see really a much, much better appearance than what we started out with, which was that. So I think there are lots of other cases that I can show you, but we'll wind up with that and just talk about just a few other advantages, which is that eye banks are also offering pre-prepared PDEC grafts now. So if you're worried that you won't get a PDEC graft, then that's a possibility. In fact, our eye bank would also be happy to send it to you if you want. The graft size is something that everyone asks me about. Do you get small grafts? No, I generally get 7.5 very easily. Mostly I get about 8, 8.5, and that translates to a very good size for you. Proper bubble creation, there are lots of techniques that you can use to make sure that you get good grafts. Remember also that the size of the graft that you get also depends on the size of the donor, white to white. So that's one thing. And of course, the advantage of using younger corneas. Just to show you, sorry, the size of the graft that you can actually get. I'll skip all this part and just come to just the graft size here. So you can see, you can get extremely large and very, very, good graft sizes, even with PDEC, which you wouldn't probably believe unless you actually see them. And you can see that's a really nice graft, which is extending almost, very well across the cornea. Standard 8.5 is very, very common for me to get. So that concept that the PDEC grafts are small is really a false concept, and you can get extremely good graft sizes. So these are some of the post-ops, and I also have this book, Mastering Endothelial Keratoplasty, if anyone would like to read it, which goes on about DSEC, DMEC, PDEC, and all the other techniques. With that, I'll come to the end of my talk. Thank you so much.
Amazing videos, Susan, just mind-boggling. Dr. Rajesh, can you take a question for her?
Well, these are definite advantages of PDEC. Even Professor Dua has been showing some of the videos, and how the presence of Dua's layer in this graft can help in the manipulation, and you can definitely look at using the pediatric tissues. I think Namrata also has some experience with the PDEC graft. Maybe she can give some points as to what their experience has been.
So we did start doing PDECs mainly for the reason because sometimes the donor corneas would come, which would be of a younger donor, and there would be patients waiting for endothelial graft, and because of the age, we could not use them for DMEC. So we did start it off. In the beginning, of course, I think there is a learning curve because there is a bubble burst. If you put too much of air, or size of the graft is something which you may not be able to manipulate always. Sometimes the bubble is small, sometimes it is large. Then again, there are times when the type 1 bubble or type 2 bubble, I mean, that is something on which you will need time to get control on, and then you have to convert a PDEC graft to a DMEC graft, which is a very tough thing to do. That is what I feel, especially when you are dealing with the younger donors, and it becomes then tougher even to put them inside because they are very tight scrolls. But the cases which do well in the sense that I also feel, and I could be wrong, Susan, that you are putting the graft with the help of a reverse Sinski kind of an instrument, or by cannula, you are kind of opening that parachute and then putting it there. So the only thing is that you are touching the peripheral endothelial cells. Now, you can say that you're using larger grafts and it doesn't matter. But like we do DMEC, it's like a non-touch technique. We don't touch the graft at all, except for one place to just pull it up. So that way, I feel that these are the things, especially in the learning curve, especially when you are, when you are beginning to do PDEC, these are the problems which could be there, and these should be addressed. Of course, in cases like it's a firmer graft, it's a more sturdier graft that way that it will not tear, like you so beautifully showed, and it will not it's not flimsy, it's got a splint attached to it. So the handling is much better because it doesn't, flip. And once you put it in the correct direction, it will remain there for quite some time and it will not flip again and again. So those kind of advantages are really there. And then younger donors, or you can say donors in pediatric age group, is again one of the advantages. But I think I'm sure Dr. Rajesh, you would have done DMEX even with younger.
I did use this technique, which again Frank Price and Massimo Busin had also described. They called it the hybrid DSEC, or hybrid DMEC, where they had a small stromal rim and they prepared the tissue by pneumatic dissection. We did try it, but we were then inserting it into the eye pretty much like what we were using a DSEC graft. So we used to pull through these grafts into the eye, and patients did do well. The only problem that we faced was we started seeing a little bit of an interface haze in these cases, which could have been the retained viscoelastic, which is much, unlike a DSEC graft, which has more form and rigidity. Here, the tissue is so floppy that any viscoelastic that you put on the endothelium can get transferred to the stromal side as well. So that could have been the reason. The second thing is that sometimes you see folds in the graft, because unlike DMEC graft, which can, once you put an air, it irons out all the folds. Here, you have to physically remove those folds, especially if you are using a reverse Sinski to move the graft in one direction or the other. Against an air bubble, you will see those linear folds, which if you don't remove them, they tend to affect the visual acuity in the long run. And from Dua's paper, the ideal size of the bubble comes to about 8.5. And even if you try to punch it out, sometimes in the periphery, using a scissors, very difficult to achieve larger size graft. The ideal size is between 7.5 and 8 in my hands. And recently, there has been a description of a technique where the peripheral DM can be scraped before you inject the air. Thereby, you can avoid the formation of the type 2 bubble. So you will get only a type 1 bubble when you prepare the graft. The disadvantage is that if you have a pediatric donor tissue and you inject air and you fail to achieve a type 1 bubble, then you are in a dilemma as to what to do with that tissue, because now it's all with the stromal emphysema. Then you have to either put it back in the medium, wait for the emphysema to clear, and then use it later for a PKP if you have failed to achieve a big bubble. So there is a learning curve achieved to this technique, and I think you have to handle the tissue much more carefully because you are doing too many steps which involve the endothelium.
So I think I agree with that there is a learning curve. And definitely as for any endothelial keratoplasty, except I think DSEC, which has a very short learning curve, everything else does have a long learning curve. What we do, just a couple of points about, what was mentioned, the difficulty in assessing the size of the graft, and also in not knowing whether the graft would burst or not when you're injecting. What I do for preventing that and for getting a very controlled expansion of graft is that I inject air, and once the bubble has reached a small size, so I'm not doing a rapid injection, I'm doing a small, slow injection, superficial needle placement. Of course, needle need not be inserted all the way to the center. You can keep it at the periphery and you get a small central bubble. Once you do that, you advance the needle and you change over to trypan blue. If you don't want trypan blue, you can just change over to storage medium or BSS or whatever. And then you expand it. And then your expansion becomes much more slower, and you can get a controlled graft size because you're no longer injecting air, which can rapidly expand. That's one thing. The second thing is about the handling. I think since we started it, we've almost stopped DSEC completely, except when we had a trainee who came once and wanted to learn DSEC, and not done PDEC also for I personally have not done for the last at least I think 3 years. So the advantage that PDEC gives me is I'm so comfortable now doing it that I don't mind doing this. I do it without a second thought in all complex cases also, including one-eyed patients. In fact, just before the surgery, I did a practicing doctor one-eyed patient with Fuchs. That was, of course, a simple case. But all complex cases also you can do. So that is, I think, an advantage which DMEC may not offer you every time, of the confidence that you are going to be able to do it perfectly without problems. The last point, I think, Rajesh, you mentioned something in the end. What was that about? You said something about...
avoiding a type 2 bubble. You can do
Right. That's the Soper's technique. That was what you said, the Mark Soper's technique, where you scoring around that thing. And I think that greatly helps. That does greatly help. Also, if you get emphysema and you're wondering, you've taken a small young eye and you get emphysema, and now you think, are you going to have to throw that bubble away? No, don't do that, because that's when you can go inject again with saline or BSS or storage. I generally just use the storage medium. or tropanidyl also. So storage is good because you go superficially and you inject. If you don't get it, you go a little more superficially. The edema will allow you to go superficially because once you inject a bit, it becomes edematous. And so when you do that with the medium, you can always expand it. So you don't have to really discard the bubble. That's something. Very rarely I've got a type, of course, type 2 does happen. I'll not say that it doesn't happen. Type 3 happens once in a while. When you get a type 3, identify it immediately and rupture that the type 2, which is forming in the periphery. The minute you rupture it, just give a small needle prick and just give a small tear in the end, then you can get the type 1 to preferentially expand. And once that happens, you can cut it either a little eccentric or just use that part even as a flap. It doesn't matter if there's a small partial type 3 in the edge. If most of it is type 1, then you can have still gone ahead with it and completed the surgery.
So are we done? Any more questions to ask, or shall I give my concluding remarks?
Go ahead with your concluding remarks.
All of you all are tired, and you all should admire me for hearing so much of cornea amidst you all.
I have to thank Dr. J.S. Chittial sir for giving tissues for PDEC, because when we were doing this thesis, there was COVID in between and there were absolutely no tissues. And as soon as the COVID went off, it didn't go off, but there was, a lull period for 2-3 months. So he was kind enough to, allow us to do PDEC with all the tissues so that we could complete the thesis. Otherwise, it would have been a challenge to do it.
Congratulations. I think your papers just got published in JCRS with IOCT and PDEC, if I'm right.
Yeah.
So congratulations for that.
So I'm sure we have had a great learning today with the expert panel and an absolutely amazing set of speakers. And there has been so much of knowledge sharing moment today. My deep felt thanks to the great panel and speakers. My very special thanks to my co-moderator, Dr. Rajesh Fogla, without whom this webinar couldn't have been a success as it should have been. Thanks a lot. My thanks are due to all in my ARC panel. Thanks a lot to Mr. Kripal and his team. Special thanks to Mr. Sunil, our webinar admin, who could not contribute as much as he usually does. He's quite amazing. Our thanks to Sai and Manjula from Numerotech for their constant support. Our deep felt thanks to Entold for their constant support and encouragement and sponsoring all our webinars. And finally, thanks a lot, dear attendees, for being with us and helping us keep coming back to you with webinars on different themes. Our prayers that all of you stay very safe and remain absolutely careful. Thank you, one and all. Thanks a lot.
Thank you, ma'am. Thank you so much.
Thank you. Thank you very much. Bye-bye.
Thank you. Bye-bye.